A member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Dr. Lee, that concludes my opening comments.
Thank you, Dr. Wharton. We will move on to roll call and then a few announcements to set the stage for today's discussion. For the ACIP members, I'll ask that you state your name, your affiliation, and whether you have any conflicts of interest. We will start with Dr. Bell.
Good morning, Beth Bell, clinical professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Dr. Cotton?
Good morning, Camille Cotton. I'm the clinical director of transplants and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Chen?
Wilbur Chen, professor of medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health, and director of the travel medicine practice here at university. I have no conflicts.
Thank you. Dr. Sineas.
Good morning, Sybil Sineas. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Daly?
Good morning, Matt Daly. I'm a general pediatrician and also a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and I have no conflicts of interest. Thanks.
Thank you. Dr. Paling?
Good morning. It's Kathy Paling. I am a pediatrician, professor of pediatrics, epidemiology, and prevention at Atrium Health Wake Forest Baptist Wake Forest School of Medicine. I have no conflict. Thank you.
Thank you. Dr. Talbot?
Good morning, Kip Talbot, professor of medicine and health policy, an adult infectious disease doctor. Thank you.
Thank you. Dr. Lair?
Good morning. This is Jamie Lair. I'm a private practice family physician in Ithaca, New York, and I have no conflicts of interest.
Thank you. Ms. Bata?
Good morning, this is Lynn Bata. I am a public health nurse functioning as the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Long?
Good morning, I'm Sarah Long. Pediatric infectious disease physician and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Thank you. And this is Grace Lee, professor of pediatrics at Stanford University School of Medicine and chief quality officer at Stanford Medicine Children's Health. I have no conflicts. Let me just confirm, are there any additional ACIP members on the call right now that I haven't called on? Okay. Well, for our committee, we do have quorum today, so we're able to proceed. For our ex officio and liaison members, I will announce the organization name and then please indicate your first and last name on behalf of your organization. We will start with the Centers for Disease Control and Prevention.
Hi there, this is Dimitri Daskalakis. I am representing CDC.
Thank you. Centers for Medicare and Medicaid Services.
Good morning, this is Mary Beth Hance representing CMS.
Thank you. Food and Drug Administration.
David Kasla representing Food and Drug Administration.
Thank you. Health Resources and Service Administration.
Commander Reed Grimes representing HRSA.
Thank you. Indian Health Service.
Good morning, Matthew Clark representing Indian Health Service.
Thank you. National Institutes of Health.
Good morning, John Bible representing the National Institute of Health.
Morning and thank you. Office of Infectious Disease and HIV/AIDS Policy. Okay, we'll move on to the American Academy of Family Physicians.
Pamela Rockwell, AAFP. Hello.
Thank you. American Academy of Pediatrics. I believe if we have the American Academy of Pediatrics Red Book on.
Yeah, this is Sean O'Leary representing AAP.
Oh, thank you, Dr. O'Leary. And
David,
for the Red Book?
David Kimberlin, AAP Red Book editor.
Thank you. American Academy of Physician Associates.
Good morning, Marie-Michelle Léger.
Thank you. American College Health Association.
Pibby Chai, present.
Thank you. American College of Nurse Midwives. American College of Obstetricians and Gynecologists. American College of Physicians.
Dr. Jason Goldman, representing American College of Physicians.
Thank you. American Geriatric Society.
Educator for AGS.
Thank you. America's Health Insurance Plans.
Good morning, Jessica Grub, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Thank you. American Medical Association.
Sandra Freihofer, internal medicine physician in Atlanta and adjunct associate professor at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Yes, good morning, Stan Grog, present.
Morning. American Pharmacists Association.
Good morning, Kelly Good, representing APHA.
Thank you. Association of Immunization Managers.
Good morning, Shelley Fiskus, representing AIM.
Thank you. Association for Prevention, Teaching, and Research. Association of State and Territorial Health Officials.
Sorry, Catherine Williams, APTR. I missed the mute.
Thank you. Sorry, we're moving quickly. Association of State and Territorial Health Officials. Biotechnology Innovation Organization.
Phyllis Arthur and Emily Acker for Bio. Good morning.
Good morning and thank you. Council of State and Territorial Epidemiologists.
Hello, Paul Cieslak representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Kelsey Young here on behalf of NACI.
Thank you. Infectious Diseases Society of America.
Good morning, Jeff Duchin representing IDSA.
Thank you. International Society for Travel Medicine.
Good morning, Elizabeth Barnett here for ISTM.
Morning, thank you. National Association of County and City Health Officials.
Good morning, Jeff Duchin again representing National Association of County and City Health Officials.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield for NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Bob Hopkins and Marla Dalton for National Foundation for Infectious Diseases.
Thank you. National Medical Association.
Good morning, Pat Whitley Williams for the National Medical Association.
Thank you. Pediatric Infectious Disease Society. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Thank you. Good morning. Society for Adolescent Health and Medicine.
Good morning, it's Amy Middleman for SAM.
Thank you. Society for Healthcare Epidemiology of America.
Vivian Rocha for SHE.
Thank you. And with that, I'm going to go back and ask Dr. Brooks if he could please state his name, his affiliation, and any conflicts of interest.
Good morning, everyone. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation. I have no conflicts.
Thank you, Dr. Brooks. Are there any additional liaison members who are not able to identify themselves? Okay. Well, thank you very much. Before we get started, I just want to take a moment to thank my ACIP members and our liaison members and our CDC colleagues for coming together for today's meeting. I may have lost count. I think we are at 34 additional meetings since the pandemic began, but I'm sure someone will correct me on that. But this is a lot of additional work, and I am just very appreciative that everyone takes the time to be able to come join together and have these deliberations for these public meetings. Next, we will take a moment to have a few brief remarks from our colleagues at CDC and FDA to help provide additional context for today's meeting. So first, I would like to introduce Dr. Mandy Cohen, who is the Director of the Centers for Disease Control and Prevention. Dr. Cohen, the floor is yours.
Well, good morning, Dr. Lee. Can you hear me?
Yes, we can. Thank you. Please go ahead.
Well, first, Dr. Lee, thank you so much for your leadership. I also want to thank Dr. Warden for her leadership on the CDC side. I just wanted to join briefly this morning to say thank you. I had an appreciation for your work as Secretary of Health and Human Services for North Carolina, and frankly, as a mom and a wife and a daughter, for all of the work that you have done throughout this pandemic. But now as the new director of the CDC, I think I have even greater appreciation now for the amount of work that goes into preparing for each and every one of these decisions and recommendations, the amount of work that I know you are going through each and every day, that you're taking time out of your other work that you're doing. I just am so grateful for your service to this committee and to the country. I think you know that your work is critical, but I just wanted to say thank you once again. And you know, we're in such a different place than we were in the beginning of the pandemic, which is wonderful. We're in our strongest position yet to fight COVID-19, as well as flu and RSV this winter season. We have more tools, and I'm excited for the first time ever we have tools against all three of the major virus pathogens. I know you're going to be focused on COVID today, but I know we're coming back to even just next week to focus on RSV. So again, so much time and commitment of this group. I'm just so grateful. I think you know at CDC, we are centering our efforts around building trust, increasing transparency and communication, and making sure that we're bringing evidence, data, and best practices to bear to protect and improve health across this country and frankly, the world. We are really making sure that we're thinking about sharing simple, clear information with common sense solution and steps that people can take and their loved ones, particularly as we think about this coming fall and winter respiratory season. So we're trying to use all the tools at our disposal to build that trust. And you are a very big part of that work. And so thank you for all that you continue to do. I know today you're going to be hearing a lot of data, and thank you to the teams that have done the scientific work, to the teams of the CDC that have been putting this together and working side by side with the work groups and others, and Dr. Lee, again, for your leadership. You're going to see data that goes through all the benefits and the risks of these updated COVID-19 vaccines, and this is going to include comparison of the burden of COVID-19 hospitalization to other vaccine preventable diseases like flu. You're also going to hear about recent trends on the rates of COVID hospitalizations. As you know, we're already in the midst of an increase in hospitalizations for COVID-19. And this virus continues to keep us humble. It has continued to change. And we have been working hard with many partners across the healthcare ecosystem to make sure we can continue to stay ahead and give folks the most tools that they can to protect themselves. You know, I know that this group has such a deep understanding of the U.S. immunization program and how important it has been to improving and protecting health for decades. And again, I know that's going to be brought to bear here as we look at some of the additional ways in which we've used universal vaccine recommendations, such as in flu and others, to make sure that we're preventing diseases. So just to wrap up here, I so value the expertise of this group and your ability to synthesize all of these different kinds of considerations. There are different data inputs that you're looking at and the context that you're looking at it. Let me just leave you with the things that are the most important to me as you go into the day. One, that we together are able to communicate clearly and effectively to the public about this vaccine, right? So again, going back to that trust, we want to make sure that we are able to communicate clearly and effectively to the public about this vaccine. So thank you for that. And then secondly, what's important to me is that we're able to make this vaccine available in an equitable way so that folks have equitable access to this important tool. So again, the communication about clear and effective communication and equitable access. So those are the two things on my mind. And I know you're going to get into your work today again. And I'm so grateful for everything that you are doing and the time that you're giving to this work. So I'll turn it back over to you, Dr. Lee, to get to work and again, thank you so much for your service.
Well, thank you so much for joining us this morning, Dr. Cohen. We really appreciate it and appreciate your comments. With that, we will move on to Dr. David Kaslow from the FDA. He is the Director of the Office of Vaccines Research and Review and the Center for Biologics.
Thank you, Dr. Lee. And let me echo from the FDA, Dr. Cohen's thanks to ACIP and the CDC. So yesterday, FDA took 4 regulatory actions on mRNA-based COVID-19 vaccines, 2 approvals and 2 authorizations. Both of the mRNA vaccines that were previously approved in the United States were updated to approve a single-dose regimen in individuals 12 years of age and older. That single-dose regimen is now approved for the 2023-2024 formula that includes a monovalent or a single component encoding the viral spike glycoprotein of SARS-CoV-2, Omicron variant lineage XBB.1.5. Section 8.6 of the prescribing information, titled Immunocompromised Individuals, notes that the Centers for Disease Control and Prevention has published considerations related to COVID-19 vaccination for individuals who are moderately to severely immunocompromised. FDA also authorized yesterday both mRNA vaccines, which were previously authorized in the United States for a bivalent COVID-19 vaccine in individuals 6 months to 11 years of age. Both of those mRNA vaccines are now monovalent 2023-2024 formulas and are now harmonized for a single-dose regimen in individuals 5 years through 11 years of age, regardless of previous vaccination status. Unvaccinated individuals 6 months through 4 years of age continue to be eligible to receive 3 doses of the now updated authorized Pfizer-BioNTech COVID-19 vaccine or 2 doses of the now updated authorized Moderna vaccine. Individuals 6 months through 4 years of age who have been previously vaccinated against COVID-19 are eligible to receive 1 or 2 doses of a now updated mRNA vaccine, the timing and number of doses depending on the number of previous COVID vaccine doses received. Finally, additional doses of the updated mRNA vaccines have been authorized for individuals 6 months through 11 years of age with certain kinds of immunocompromised. These 6 month to 11-year-olds should complete, or 2-year-olds should complete at least a 3-dose series with an age-appropriate dose and dosing schedule of a COVID-19 vaccine. And at least one of those doses should be a COVID-19 vaccine 2023-2024 formula. And with that, I'll turn the floor back to you, Dr. Lee.
Thank you very much, Dr. Kessel. I just wanted to take a moment to thank you for your work at the FDA to ensure that the regulatory actions are easier to implement, especially for our children. Before we move on to the last set of comments, we have received a lot of requests for information around the Novavax vaccine. I know you may not be able to comment on that, but is there anything you can tell us from the FDA?
Sure, no, thank you for that question. So with respect to other COVID-19 vaccines, as you pointed out, I'm not at liberty to disclose or discuss if, what, or when a submission has been made to FDA. However, a sponsor applicant is always free to do so. What I can say, both from the office and from CBER, is, and what we said repeatedly is, and what we heard from VRBPAC both in January and June, is that there is an urgent need for alternatives to mRNA-based vaccines, including protein-based vaccines. And so in that regard, we will review such a submission expeditiously. I also wanted to point out that FDA co-hosted a workshop with BARDA on this topic in April this year, in which challenges, including the time needed to update vaccine composition of protein-based vaccines, were discussed. And what I would say is really, for any additional information on this topic, I would kindly defer to the sponsor. So with that, I'll turn it back to you, Dr. Lee.
Thank you, Dr. Kessler. We appreciate that. We have one additional comment. Introducing Dr. Dimitri Daskalakis, who is heading up or leading NCIRD from the CDC. So Dr. Daskalakis, would you like to make a few comments?
Thank you so much, and great to be here in my new acting status as the NCIRD director. So again, I'm really excited to be here and to sort of hear the process that ACIP has gone through. I'll echo Dr. Cohen and her comments about just the great amount of work that goes into this, and just the gratitude we have for all who serve on the committee to make sure that we are continuing to look at the data so that we can best serve the people of America and their health. I think otherwise, I would probably hand it right back over to you so we can. Specifically a Novavax comment? No problem. So just on follow-up to that, so thanks to the FDA comment. So again, I'll echo that we're also aware that there's a lot of interest in having non-mRNA vaccine options available. And we also look forward to the potential authorization of the updated vaccine. It's important to note that the voting language that is going to be presented later today is inclusive of FDA licensed or authorized updated monovalent XBB containing COVID-19 vaccines, including those that may be licensed or authorized in coming months. So this would allow such vaccines to be incorporated into programs immediately following FDA regulatory action, and that won't require that ACIP be reconvened. So I hope that this will facilitate the availability of the Novavax vaccine once FDA has reviewed and potentially authorized. Thank you.
Thank you so much for your comment. With that, I believe we are ready to move on to our first session for today, which I'm going to turn over to Dr. Matt Daly, who is chair of the COVID-19 Vaccines Working Group, to provide an introduction and overview of today's session.
Thanks very much, Dr. Lee. Good morning, everyone. I'll be introducing the session today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. So as we just heard from Dr. Kaslow, FDA had a number of authorizations and approvals yesterday. He summarized those so clearly, but just to reiterate a couple points, FDA updated the COVID-19 vaccine emergency use authorizations, or EUAs, yesterday for the use of 2023-2024 mRNA vaccines for all doses and indications administered to individuals ages 6 months to 11 years. In addition, the FDA approved supplemental biologic license applications, or BLAs, for the use of 2023-2024 mRNA vaccines for all doses and indications administered to individuals ages 12 years and older. Next slide, please. So I did want to review what we discussed at the most recent public ACIP meeting on June 23rd of 2023. At that meeting, we heard a number of updates, including to COVID-19 epidemiology and vaccine effectiveness among pregnant persons and infants. We also heard and had a detailed discussion about infection-induced and hybrid immunity. And then following this, we summarized sort of the material presented in a number of work group considerations with respect to COVID-19 and pregnancy. Pregnancy remains a risk factor for severe COVID-19 disease. And based on the available data, COVID-19 vaccination substantially improves outcomes for pregnant people and their infants. And then in the context of infection-induced immunity and hybrid immunity, the summary of what was presented there includes the following. Hybrid immunity likely does provide better protection than either infection or vaccination alone. However, protection is likely influenced by multiple factors, including prior vaccine doses, prior infection, time since vaccination or infection. But it's important to highlight in the context of our discussion today that protection wanes over time following infection and following vaccination. Next slide, please. So then to review the deliberations of the ACIP COVID-19 vaccines work group between that meeting and today, during that time, we've met frequently. We have been meeting almost weekly, and in that time we reviewed manufacturer data to inform monovalent XBB.1.5 containing vaccines. We reviewed the modeling of pandemic outcomes in a variety of scenarios. And what this did was look at potential impact of new variants and potential impact of different vaccine and booster coverage on the pandemic outcomes in these various scenarios. We heard a comprehensive review of COVID-19 vaccine safety, and we'll hear that again today. We then received updated data on COVID-19 epidemiology, vaccine effectiveness, and benefit risk assessment. In addition, we heard additional detail about the epidemiology of post-COVID conditions. We'll also hear some of that today in public session. And then we heard COVID-19 vaccine cost effectiveness analyses. And when I say heard, of course, I mean we sort of had a detailed discussion after presentation about that as well. And then this all led up to our review of the evidence to recommendations framework, which we're also going to hear in detail today, including that the work group discussed universal vaccination recommendations versus risk-based strategies, and requested and then reviewed additional data on burden by age group and by presence of underlying condition. Next slide, please. So the agenda for today is as follows. We'll first hear from Dr. Thornburg, who will review the current landscape of SARS-CoV-2 lineages. Then we'll hear from Dr. Havers, who will review COVID-19 epidemiology. Following this, we'll hear from Dr. Saida, who will review post-COVID conditions with us. Following this, we will hear from Dr. Link Gellis, who will review COVID-19 vaccine effectiveness. Following this, we'll hear from Dr. Prosser, who will review an economic analysis of COVID-19 vaccination. And then following this, we'll hear from Dr. Klein, who will review COVID-19 vaccine safety surveillance. I think at this point, we'll all take a breath and then take a break. And then after this, we will hear from Dr. Priddy at Moderna, who will review Moderna's 2023-2024 COVID-19 vaccine. We'll then hear from Dr. Dubovsky from Novavax, who will review Novavax's 2023-2024 COVID-19 vaccine. And then after this, we'll hear from Dr. Mojarid, who will review Pfizer BioNTech 2023-2024 COVID-19 vaccine. Next slide, please. Following this, we'll have a break, and then we'll hear from Dr. Wallace, who will review the evidence to recommendations framework for the use of COVID-19 vaccines. Then we'll hear from Dr. Peacock, who will provide an overview of important considerations around COVID-19 vaccine implementation. And then we'll hear from Dr. Twentyman, who will review the Bridge Access Program. Following this, we'll have a discussion, and then a break, and then a public comment, and then a break, and then we will vote on the use of 2023-2024 COVID-19 vaccines in persons ages 6 months and older. Next slide, please. So my sincere thanks to the ACIP COVID-19 vaccines work group members who've spent countless hours reviewing everything that I presented so far today. So this includes ACIP members, ex officio and government members, the CDC leads, Dr. Wallace and Dr. Reagan. In addition, we have a number of liaisons who critically contributed to this, and a number of consultants. Next slide, please. And then there's a number of CDC participants who, again, are working countless hours to provide the data for which we are deliberating and on which we are deliberating. Next slide, please. Thanks. I pass it back to you, Dr. Lee.
Thank you, Dr. Daly. We will take a moment to recognize our ACIP member, Pablo Sanchez. If you could please just state your name, your affiliation, and if you have any conflicts.
Thank you, Grace. Pablo Sanchez, I'm professor of pediatrics at the Iowa State University School of Medicine. And I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital in Columbus, Ohio. And I have no conflict. Thank you.
Thank you. With that, we'll move on to Dr. Natalie Thornburg, who will discuss the current landscape of SARS-CoV-2 lineages.
Thank you, Dr. Lee. Can you hear me okay?
Yes, we can. Please go ahead.
Great, thanks. Next slide. So I'm going to talk to you today about the current landscape of circulating SARS-CoV-2 lineages. This is our weighted estimate in nowcast predicted estimates of currently circulating viral lineages. Just a reminder on how you look at these kind of graphs. On the left side of the graph are weighted estimates. They're variant proportions based on reported genomic sequences. So these are generated from actual sequencing results. And then along the x-axis on the bottom are the bi-week periods that we report the data. So 2 week, the data are bucketed into 2 week bins. And then we use those weighted estimates, the actual sequences generated, to model into the present. And we do that because it takes at least 2 weeks for sequences, for specimens to make it from diagnostics labs to sequencing labs and then complete the sequencing workflow and analysis. So we have to model into the present tense. So on the right side of the graph, you see the nowcast model with the most recent update having occurred on September 1st. And there will be another update that posts at the end of this week where we don't expect any dramatic differences from what was posted about a week ago. And so this looks like there's a lot of viral diversity at the moment, but there actually is less viral diversity than all of these colors indicate. All of these viruses and all of these prevalent viruses are XBB lineage viruses, except for some of the ones listed at the very, very bottom of the list on the right. But those you'll see the proportions are 0 to 0.1% of viruses. So really everything that is circulating currently in any significant proportion are XBB lineage viruses. They look very different because of the use of aliases. So once a viral lineage gets added a lot of numbers onto it, an alias is assigned, and that is a letter with a number. And those aliases are assigned just in order. So they're not linked back to that original name. So EG5, which is the most predicted to be the most prevalent circulating lineage right now, is an XBB lineage virus. Now, I mentioned the diversity is less than what this appears. Many of these lineages actually have identical spike sequences. We've observed this before, where we see convergent evolution in viruses evolving to have the same substitutions in spike via multiple different lines of evolution. And I'll show you that 2 slides from now. So take-home message is, currently, almost all circulating lineages of viruses are XBB lineage viruses. Next slide, please. I showed this slide at VRPAC in June. And so we see some differences now. I'm going to show you what I showed in June, and then in the next slide, I'll show you viruses that are circulating currently. These are substitutions that were observed in the receptor binding domain portion of spike in comparison to BA4, BA5 spike sequence. So as a reminder, the receptor binding domain is the portion of the spike protein that binds to the cellular receptor ACE2. So that's sort of the most important target for neutralizing antibodies is the receptor binding domain. So substitutions in that area are most likely to generate reductions in neutralizing antibody responses. So these are all anchored to BA4, BA5 spike sequence because that was the formulation of Omicron that was included in the bivalent booster last year. These were viruses that circulated from September 2022 to June of this year, 2023. And at the time, the viruses that were increasing in proportion were bolded. So you can see them at the bottom of this table. And what I want you to see is slow but definite accumulation of substitutions in the receptor binding domain that likely led to incremental reductions in neutralization over the course of the year. Next slide. Now this is a very similar slide, but with currently circulating viruses. So not going all the way back to September 2023. This is what's circulating right now. And this is anchored to the reference sequence XBB.1.5, since that is the proposed formulation of updated COVID-19 vaccinations. And so the sequence of each place where we're seeing some substitution is listed on the top. That's what's in XBB.1.9. You can see fewer columns, and that just means we're seeing fewer substitutions in currently circulating viruses in comparison to the vaccine formulation, XBB.1.5. And in currently circulating viruses, you'll see one to two substitutions in the receptor binding domain. So not a lot of substitutions in the receptor binding domain. You will see consistently, we are seeing a lot of the currently circulating viruses, especially those that are increasing in proportion, which are bolded, have an F to L substitution at residue 456, maybe indicating that the viruses are finding some sort of advantage by evolving this substitution. Next slide, please. And this was a slide I showed at VRBPAC in June. At the time, there was consideration of either utilizing an XBB.1.5 formulation of vaccine or an XBB.1.6 formulation of the vaccine. This is a crystal structure of spike shown sort of on the bottom in gray. One protomer, or one piece of the three-part trimer of spike, is colored with the different portions of spike colored differently. Receptor binding domain is red and green, with the motif is a smaller portion of the receptor binding domain that really directly abuts ACE2. ACE2 would be attached to the cell. That's the cellular receptor up there on the top, kind of in gold. And the substitutions in those XBB viruses in comparison to BA5 spike are in squares. And then there were two differences between these two proposed vaccine strains that are highlighted in green, one in the receptor binding motif and one in the N-terminal domain, which is blue. So they are very, very, very similar spike sequences, XBB.1.5 and XBB.1.16. Next slide, please. All right. So those viruses that I just talked through are greater than 90%, really closer to 99% of circulating viruses are all of those XBB lineage viruses that have one or two substitutions in comparison to XBB.1.5. I'm going to go through a couple of slides talking about BA.2.86, just because it's garnered a lot of attention and a lot of attention recently because it is very different than XBB lineage viruses. So this was first detected in early August, I believe, and it is a lineage of virus that's actually most closely related to BA.2. BA.2 is an Omicron that precedes XBB viruses. XBB viruses are BA2 lineage viruses, but they're chimeric viruses, and so this seemed to have evolved independently of XBB lineage viruses and is quite different than XBB lineage viruses. So BA2 and its lineages circulated in the spring of 2022, before the BA.5 wave, which happened late last summer, early last fall, after the really big Omicron wave, which was BA.1 lineage viruses in December, January, February of 2022. So it was sort of March, April, May circulation in the US when we actually didn't have a whole lot of cases of COVID-19 at that time. So you can see a phylogenetic tree on the bottom left that was pulled from next strain and a blow up of all the sequences that have been generated on the right. And there's it's kind of evolving in two different, I don't want to say clades, but two different versions of BA.2.86 right now. There are two US sequences that are highlighted with yellow errors. So one that was detected in Michigan and another sequence that was detected in Ohio. Next slide, please. So BA.2.86 has more than 30 amino acid substitutions in spike in comparison to XBB.1.5. And as far as the sequencing goes, that's a similar change in amino acid of spike during that Delta to Omicron shift. There's variations between sequences due to missing data and sequencing artifacts, but then there also may be some variations in some of the viruses themselves. Again, it was first detected in specimens collected in late July 2023. And as of last week, there were seven clinical specimens, 7 sequences in 7 US states, and then there was 1 additional state detections in wastewater. We may have a couple more this week and in coming weeks, but the take-home message is we have a very small number of viruses detected in the United States thus far. And as of last week, it had been detected in 10 different countries. We're still dealing with a fairly small number of sequences. I do want you to look at the alignment on the top. The alignment is not just the receptor binding domain. The receptor binding domain is shown in red. This is substitutions represented across the whole spike protein, and terminal domain being in blue, receptor binding domain in red, and S1, S2 interface in purple and sort of peach colored. The top is BA.2, the descendant, or the parental lineage. The second line is XBB.1.5, the proposed current formulation of the vaccine. And then the bottom two are BA.2.86 sequences, substitutions. And what I want you to see is just there's a large number of substitutions in BA.2.86 in comparison to XBB.1.5. Next slide. So because of this large number of substitutions, there is some concern that there could be a more dramatic reduction in neutralization against BA.2.86 viruses should they take hold and increase in proportion, which they have not done yet, and we cannot say with certainty is going to happen. So many labs have now generated data for neutralization. I'm going to show 2 studies, but there have been more studies. There's more studies posted every day for neutralization. This study is out of David Ho's laboratory. This is generated through the SAVE network, which is a network of laboratories that's funded with our SARS interagency group partner, or SARS interagency group partners at NIAID. So this is pseudovirus neutralization. So it's it's not in a SARS-2 backbone. You use a different virus backbone and put spike on the surface of it and see just sera that how much virus can be neutralized by different kinds of sera. So in the left panel is 3 shots original vaccine formulations and 2 shots of last year's vaccine formulation. The middle panel are from convalescent sera for persons who had BA.2 infections, and on the right panel are convalescent sera from persons who had infections with XBB lineage viruses. And the message I want you to look at here is sort of the bottom 2 columns in each graph are 2 BA.2.86 viruses. And there is still good neutralization of BA.2.86 viruses, pseudoviruses, in comparison to XBB.1.5 virus, using really all of the different types of sera. And so even though there could have been a reduction in neutralization because the virus is so different, the laboratory is just not observing a reduction in neutralization. Next slide. Similar type of experiment done also supported by the SAVE network and our SARS interagency group from Dan Baruch's laboratory, also pseudovirus neutralization. These are persons who received the vaccine formulation from last year. Shortly after vaccination, that's what baseline is in the left panel. 6 months after vaccination in the middle panel, and then 6 months after vaccination from people who also had an XBB infection. And very similar to Dr. Ho's laboratory data, if you look at the far right corner, far right-hand columns of this graph, if it's BA286, it's in red. They did not observe a dramatic reduction in neutralization of BA.2.86 pseudoviruses in comparison to XBB.1.5 viruses, although of course this is with people who have received last year's formulation of vaccine in baseline on the left, and those who had had an XBB infection on the right. And in reality, they actually saw a little bit higher titers against XBB or BA.2.86 pseudoviruses. So there have been, since these two studies have been posted, there have been a couple other studies posted. One is with recombinant viruses. So it's an authentic, well, it is a full SARS-2 virus, not in the backbone of another virus, but was generated in the laboratory, and they observed similar results with no dramatic reduction in BA.2.86 neutralization. Next slide, please. So as a reminder, more than 90% of circulating viruses are XBB lineage viruses with an additional 1 to 2 substitutions in RBD. Oops, I'm sorry, this slide is not correct, but okay. More than 90% of circulating viruses are XBB lineage viruses with 1 to 2 additional substitutions. BA.2.86 is a newly detected lineage with 30 amino acid substitutions in spike. Thus far, the number of viruses detected is still low. Sequence numbers are too low to calculate proportion though. So we don't know if BA.2.86 will be of any significant circulation. Preliminary pseudovirus neutralization data generated by multiple labs do not indicate a large reduction in neutralization activity. We have, and I apologize, these slides got swapped during reviews. We have, CDC has generated 2 authentic isolates of BA.2.86, one confirmed and one putative. We are in the process of distributing BA.2.86 viruses to multiple labs to do transmission studies, more neutralization studies against lots of different kinds of sera. And then we have another putative isolate, which is from a slightly different version of BA.2.86. We're also locally working on titrations before neutralization studies. And I believe this is my last slide. Next slide. Yeah, sorry. Okay, that's all. Next slide. Take any.
Thank you, Dr. Thornburg. We appreciate the detailed presentation and also just how you shared the sort of dynamic changes of the virus itself. We're going to move on to the next presentation, and we will take questions after a series of presentations. We'll move on to Dr. Fiona Havers, who will discuss COVID-19 epidemiology.
Great, thank you, Dr. Lee. So my name is Fiona Havers, and I'm going to be talking today about COVID-19 associated hospitalizations among infants, children, and adults, primarily using data from the COVIDNet network and focusing on data from this year, from January through August 2023. Next slide. COVIDNet is one of 3 platforms that comprise the ResMed surveillance network. FluSurvNet, another ResMed platform with very similar surveillance methods, will be used in several slides later on to provide comparisons between COVID and influenza-associated hospitalizations.
Dr. Havers, apologies. Could you get a little closer to the mic? Our members are having a hard time hearing you.
Oh, okay. Is that any better?
Much better, thank you.
Okay. All right, so I think many of you are familiar with COVIDNet, but as a reminder, COVIDNet collects data from more than 300 acute care hospitals in 98 counties in 13 states. The COVIDNet catchment area includes about 10% of the U.S. population. And hospitalizations reported to COVIDNet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior to or during hospitalization. And testing for SARS-CoV-2 is driven by clinical judgment and facility policies. So data on rates and basic demographic data are collected on all patients, and then clinical data are collected from an age and site stratified representative random sample. Next slide. This slide shows 2 figures. The left figure shows weekly rates of COVID-19 associated hospitalization among all age groups from March 2020, near the beginning of the pandemic, through August 26, 2023. The figure in the red box is at the same scale as the figure on the left, but includes only data from the most recent 8 months from January through August 2023. Please note that hospitalization rates have been rising steadily since mid-July. In the last 6 months, rates among adults ages 75 years and older, indicated by the dashed purple line, have remained elevated relative to all other age groups. Rates among infants less than 6 months, which is indicated by the solid gray line, are similar to rates among adults ages 65 to 74 years, shown in teal. Next slide. So I'm now going to talk specifically about COVID-19 associated hospitalizations among children. Next slide. So this is a similar graph from what we just saw, just showing pediatric age groups in those 17 years and younger. The solid red line are rates among infants less than 6 months. Hospitalization rates in this age group are markedly higher than in other pediatric age groups. Next slide. Because we are focusing today on vaccine-eligible age groups, this figure is similar, but with the rates of infants less than 6 months removed. After infants, the age group with the next highest rates of COVID-19 associated hospitalization are infants and children ages 6 to 23 months, with lower rates in children ages 2 to 4 years, 5 to 11, and 12 to 17 years. Next slide. So this slide shows the prevalence of underlying medical conditions by age group among children hospitalized with COVID-19. Overall, 54% of pediatric patients had no underlying medical conditions, but this varied widely among age groups. Generally speaking, most infants and very young children who were hospitalized had no underlying medical conditions, and those who did, among those who did, prematurity was the most frequently observed. The proportion of children hospitalized for COVID-19 who had underlying medical conditions increased with increasing age, with asthma, the yellow column, neurologic disorders in bright teal, and obesity in purple, being the most frequently observed conditions in older children and adolescents. Note that neurologic disorders is an interesting observation, as the population prevalence of neurologic disorders is far lower than the proportion seen among children hospitalized for COVID-19. Next slide. So to put COVID and hospitalization rates in context with another vaccine-preventable disease, these 2 figures provide comparisons of COVID-19 and influenza-associated hospitalizations using data from COVIDNet and FluSurvNet. Note that active surveillance for FluSurvNet for the most recent season occurred during a typical respiratory virus surveillance period of October through April, whereas COVIDNet hospitalization surveillance remains year-round. So these figures compare cumulative hospitalization rates for COVID and flu for the 2 most recent surveillance seasons. For the 2021-22 season, which runs from October 21 through September 22, and the figure on the left, rates of COVID hospitalizations indicated in the solid color lines were higher for all the 3 pediatric age groups shown relative to influenza hospitalizations, represented by the dashed lines. In comparison, for the 2022-23 season, which started in October 2022, hospitalization rates for COVID-19 were lower in all age groups compared to the previous season, and rates for influenza were higher or comparable for these pediatric age groups. Note that these rates include all patients admitted with a positive SARS-CoV-2 test and do not take into account reason for admission. In the older pediatric age groups, particularly those 12 to 17, some adolescents who were admitted with a positive SARS-CoV-2 test were admitted primarily for other reasons. So this likely happens more frequently for COVID than for influenza, and that maybe should be taken into account when comparing rates for COVID-19 and influenza in this most recent season. Next slide. In this final figure comparing flu and COVID hospitalizations among infants, children, and adolescents, the proportion of hospitalized patients admitted to the ICU by pathogen and age group were compared. A higher proportion of COVID-19 hospitalizations were admitted to the ICU relative to influenza hospitalizations, but as you can see, both pathogens cause severe outcomes in all age groups. Next slide. And this figure shows the proportion of COVID-19 associated hospitalizations by vaccination status among the vaccination eligible pediatric age groups for January through June 23. Among children 6 months to 4 years, and for those 5 to 11 years, a significant proportion of hospitalizations are among unvaccinated children, shown in orange. Only 4% of hospitalized children ages 5 to 11 years had received a bivalent booster in this time period, or prior to this time period. Hospitalized adolescents ages 12 to 17 years were less likely to be completely unvaccinated. However, as you can see, only 6% of those hospitalized had received the recommended updated bivalent booster dose. Next slide. I'm now going to transition to talking about COVID-19 associated hospitalizations among adults. Next slide. Again, this slide shows two figures covering similar time periods from what we saw earlier, but only including adult age groups. As noted previously, rates have been climbing steadily since mid-July. And rates among adults ages 65 years and older remain above those experienced in late June 2021 before the transition to the Delta period, the period of Delta variant predominance. It is notable that the oldest adult age group, those 75 years and older, have hospitalization rates that are consistently 2 to 3 times as high as those in the next youngest age group, adults ages 65 to 74 years, indicated by the solid yellow line. Next slide. This figure shows the most common underlying medical conditions among adults by age group for COVID-19 associated hospitalizations between January and June 2023. In general, the distribution of underlying medical conditions that are most common in adults ages 60 to 49 or ages 18 to 49 differ from those seen among adults ages 50 years and older. Among younger adults ages 18 to 49, the most common underlying conditions include obesity, neurologic disorders, cardiovascular disease, asthma, diabetes, and chronic lung disease that does not include asthma. Among the other two age groups, those 50 to 64 and those 65 years and older, the most common underlying medical conditions include cardiovascular disease, obesity, diabetes, neurologic disorders, and also chronic lung disease, including COPD and renal disease. The overall prevalence of these conditions is higher in adults over age 50 relative to adults ages 18 to 49. And substantial proportions of hospitalization among all three adult age groups are reported of having more than three or more underlying medical conditions, including 59% of adults 18 to 49. Next slide. This slide displays figures that compare weekly cumulative population-based rates of COVID and influenza-associated hospitalizations using COVIDNet and FluServeNet platforms, respectively. And this is just for the most recent season from October 2022 through July 2023. Again, COVID-associated hospitalization rates are represented by solid lines, and rates of flu hospitalizations are represented by dashed lines and are matched by color within age group. For the current season, or this most recent season over the last year, among all adult age groups, cumulative rates of COVID-19 associated hospitalizations were higher relative to flu hospitalizations. And please also note that the vertical axis on the two graphs are very different, and that rates are far higher in the adults ages 65 years and older on the right compared to adults ages 18 to 64, which are shown on the left. Next slide. In this figure, it compares flu and COVID-19 associated hospitalizations among adults. The proportion of hospitalized patients admitted to the ICU by pathogen and age group are compared. Note that while the proportion admitted to the ICU varies a bit by age group and pathogen, and may be marginally higher for COVID-19 compared with influenza in some age groups, both pathogens result in ICU admission for a substantial proportion of patients in all adult age groups. I will also note that the previous slide showed that rates of COVID-19 and flu can vary by age group. It's important to remember that while the proportions of severe outcomes, like ICU admission, may be similar between pathogens, age groups with higher rates of hospitalization and a larger number of hospitalizations would result in increased burden of hospitalizations with severe disease, even with similar proportions of those outcomes. Next slide. This is a similar slide that shows the proportion of flu and COVID-associated hospitalizations among adults that result in in-hospital death by pathogen and age group. Among adults, a somewhat higher proportion of COVID-19 hospitalizations died in hospital relative to influenza in most age groups. But again, the results are very similar in both pathogens. Next slide. This figure shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for January through June 2023. The percent of hospitalized adults who were unvaccinated, indicated by orange, decreased with age, with 35% of adults ages 18 to 49 who are hospitalized or unvaccinated, compared with 11% of hospitalized adults 75 years and older who remained unvaccinated. However, less than 25% of all hospitalized adults in all age groups had received the recommended updated bivalent booster dose, indicated by yellow. For adults 65 to 74 years and also 75 years and older, 81% of hospitalized patients had not received an updated bivalent booster, despite its availability in the fall of 2022, well before the period of hospitalizations shown on this graph. So in summary, next slide. Hospitalization rates have increased in all age groups since mid-July. Hospitalization rates remain highest in older adults and in young infants less than 6 months of age. Most children under 5 hospitalized with COVID-19 illness have no underlying medical conditions. A higher proportion of hospitalized children and adolescents in older age groups, those 5 to 17 years, have underlying medical conditions. And not surprisingly, most hospitalized adults have multiple underlying medical conditions. COVID-19 continues to cause severe illness, with a substantial proportion of patients being admitted to the ICU in all age groups. And clinical outcomes, while it varies a little bit by age group, are generally comparable to influenza-associated hospitalizations. And most children and adults hospitalized for COVID-19 since January 2023 had not received a bivalent booster prior to hospitalization. Next slide. I'd like to thank a number of people, including my colleagues in the coronavirus and other respiratory viruses division, as well as my FluServNet colleagues in the influenza division, and of course, all of the ResMed site investigators and staff who helped generate these data. So thank you very much.
Thank you very much, Dr. Havers. I'm going to ask our members just hold their questions, but please click them up. We're going to move on to Dr. Sharon Saida for a presentation on post-COVID conditions.
Thank you. Great. I'm Sharon Saida. I'm going to be providing an epidemiologic update on the characteristics of long COVID. Next slide. So to start, I wanted to give everyone a general framework for post-COVID conditions. Post-COVID conditions refers to a wide range of physical, mental health consequences that are present 4 or more weeks after SARS-CoV-2 infection. These conditions occur for patients with severe disease and also for patients who had mild or asymptomatic acute infection. On the left are processes that are more specific to infection with SARS-CoV-2 and include new or newly identified neurological conditions, kidney damage or failure, diabetes, cardiovascular damage, or skin conditions. And also symptoms that might have an unclear pathology that include a range of problems lasting for months after the acute infection. And these include symptoms similar to ME/CFS, dysautonomia, POTS, or other post-infectious syndromes. It also includes ongoing symptoms following MIS-C. On the right are conditions that can occur as a result of any severe illness or hospitalization or treatment, such as post-intensive care syndrome. These conditions and symptoms frequently overlap, and patients may experience of any combination. Also, please note there are many terms used to refer to post-COVID conditions, with long COVID being the most common and commonly used by the general public. The term PASC, or post-acute sequelae of SARS-CoV-2, often refers to direct pathological effects of the virus. And throughout this presentation, I'll use post-COVID conditions and long COVID interchangeably. Next slide. I'm next going to talk about what we know about the occurrence of post-COVID conditions. Next slide. To start, I wanted to show data from the National Health Interview Survey. This is from 2022, and it provides prevalence estimates of long COVID across all age groups in the US. Here, long COVID is defined as ever or currently reporting symptoms lasting at least 3 months following report of a positive COVID-19 test. And these estimates are among all respondents, so they represent the general US population. From this figure, you can see that the prevalence of long COVID increases with age. Ever having had long COVID is less than 2% among those under 18 years, and currently having long COVID is less than 1% in this age group. Among adults, we see the highest prevalence among adults 35 to 49 years, with 9% ever reporting long COVID and 4.7% currently reporting long COVID. Next slide. Using a similar question as is used on the National Health Interview Survey that I just presented, CDC and the US Census Bureau conduct an internet-based survey every 2 weeks among US adults to look at ever reporting and currently reporting long COVID. Based on this survey, the percent currently reporting long COVID has declined from June of 2022 to January of 2023, and has since remained steady from January of 2023 to June of this year. However, approximately 1 in 4 adults who currently report having long COVID report that it includes significant activity limitations. And this proportion has not changed in the past year. Next slide. In addition to reporting ongoing symptoms, long COVID or post-COVID conditions also includes incident conditions following acute SARS-CoV-2 infection. Using large electronic healthcare data to compare those with COVID-19 to those without COVID-19, we have found that there was an increased risk for 4 symptoms and 8 conditions among children who had COVID-19, and this included an increased risk for heart conditions, kidney failure, blood clots, and diabetes, and neurological conditions. In addition, among adults who had COVID-19 compared to those without COVID-19, there was a 1 in 5 increase, or 1 in 5 adults had a health condition that might be related to their previous COVID-19 infection. And these included neurological or mental health conditions, kidney failure, musculoskeletal, cardiovascular, respiratory conditions, or blood clots and vascular issues. Next slide. The symptoms and conditions of long COVID can persist for months or years after acute infection and may also emerge or reemerge over time. In a prospective study of adults testing positive or negative for COVID-19 who all had acute COVID-19-like illness, we found that ongoing symptoms decreased after 3 months, but approximately 16% continued to experience ongoing symptoms at 12 months. Many of these adults reported new emerging or re-emerging symptoms at 6, 9, and 12 months following the acute COVID-like illness. And of note, these symptoms were not unique to SARS-CoV-2 infection. In a recent publication from the Veterans Affairs patient population, they found that post-COVID conditions also decreased 90 days after acute COVID-19, but did find an increased risk of new conditions continuing for up to 2 years following COVID-19 illness. Next slide. Some of the groups that are more likely to experience post-COVID conditions include female sex, older age sometimes, adolescents have a higher likelihood of post-COVID conditions compared to younger children. Middle-aged adults compared to younger or older adults are more likely to report symptoms, whereas older adults compared to younger adults are more likely to have incident conditions. Severity of COVID-19 illness increases the likelihood of developing long COVID, as does having underlying health conditions prior to COVID-19. And those with lower socioeconomic status may also be at an increased risk for having long COVID. And finally, those who did not get a COVID-19 vaccine have an increased likelihood of developing long COVID. Next slide. And that is what I'm going to present data on next. Next slide. So this first study is a recent systematic review and meta-analysis that included 6 studies from Italy, Turkey, the United Kingdom, and the United States. Looking at a 2-dose COVID-19 vaccination, this was associated with a lower frequency of long COVID compared to no vaccination, with an odds ratio of 0.64. And a 1-dose vaccination was also associated with a lower risk compared to no vaccination, with an odds ratio of 0.6. However, a 1-dose vaccination compared to no vaccination was not significantly associated with a lower frequency of long COVID. And these results included post-COVID conditions defined both by a self-report of ongoing symptoms and the incidence of new conditions from electronic health records. Of note, these studies summarized here only included adults. Next slide. These are results based on unpublished data looking at the association of prior vaccination status with post-COVID conditions among 161,000 vaccinated patients matched to unvaccinated patients within 7 days of a SARS-CoV-2 positive test, and then further matched by age, sex, and severity of infection. This figure presents the relative risks adjusted for those variables along with race, ethnicity, comorbidity, influenza vaccination, and healthcare utilization. Compared to unvaccinated individuals, vaccinated individuals had the same or lower risk of post-COVID conditions, and many of these associations were stronger in the younger age groups. Next slide. This next slide presents data from our Heroes Recover cohort, vaccine effectiveness cohorts. Participants in this cohort collected mid-turbinate nasal swabs weekly, regardless of illness or symptoms, and then had additional swabs collected for any illness symptoms. This study utilized a case control design where participants who tested positive for SARS-CoV-2 were then asked about post-COVID conditions at least 60 days after testing positive. After adjustment for gender, age, number of chronic conditions, and the number of symptoms during the acute infection, having a 3-dose mRNA vaccine at least 7 days prior to infection reduced the odds of the occurrence of post-COVID conditions with an adjusted odds ratio of 0.76. Next slide. Using a similar design, this is a multi-study cohort of children enrolled between July of 2021 and September of 2022, and then followed for post-COVID conditions occurring at least 1 month after infection. All of these cases were during the Omicron variant period. In this study, an mRNA COVID-19 vaccination appeared to be protective against the development of post-COVID conditions among children, with an adjusted odds ratio corresponding to vaccine effectiveness of 34%, 48%, and 47% for at least one post-COVID condition symptom, 2 or more post-COVID condition symptoms, or respiratory specific post-COVID condition symptoms. Next slide. Next slide. So in summary, I want to leave you with a few important take-home messages. First is that post-COVID conditions are common following SARS-CoV-2 infection. These conditions do appear to decrease over time since infection. Further, while thousands of individuals are still impacted by post-COVID conditions, the prevalence and occurrence has decreased since the beginning of the COVID-19 pandemic. These symptoms and conditions are not unique to having had SARS-CoV-2 infection, since our definition of post-COVID conditions encompasses a very broad array of symptoms and conditions. Post-COVID conditions are associated with an increase in healthcare utilization and significant activity limitations that impact daily activities, work, and school. And there is good news in that there is accumulating evidence that COVID-19 vaccination reduces post-COVID conditions, both among children and adults. Next slide. Thank you.
Thank you very much. Next, we'll move on to our last presentation in this section before we take questions. With Dr. Ruth Link-Gillis will present on COVID-19 vaccine effectiveness updates.
Thank you, Dr. Lee. My name is Ruth Link-Gillis, and today I'll be presenting a summary of vaccine effectiveness data available from CDC studies. Next slide. VE updates today will be focused on emergency department and urgent care visits in children and adolescents, and emergency department visits, urgent care visits, hospitalizations, and critical illness in adults. Note that the information included in this presentation is meant to complement results of the GRADE analysis, and in many cases—
Dr. Link-Gillis, we can't hear you yet, but it might be that you haven't started.
We are rearranging to a different microphone.
Thank you, Dr. Warden.
Dr. Lee, can you hear me now?
Yes, we can. Thank you.
Great, thanks. Can you just go back one slide? Okay, so my name is Ruth Link-Gillis, and I'll be presenting a summary of vaccine effectiveness data available from CDC studies. Next slide. VE updates today will be focused on emergency department and urgent care visits in children and adolescents, and emergency department visits, urgent care visits, hospitalizations, and critical illness in adults. Note that the information included in this presentation is meant to complement results of the GRADE analysis, and in many cases includes updates to published studies included in GRADE. Before diving into VE estimates, I wanted to provide a bit of context for interpretation of the results I'll share today. By July and August of 2020, just before the bivalent vaccines were introduced, individuals in the U.S. had high rates of infection-induced immunity, well above 50% for age groups, except those 65 and up, which was just below. Hang on one second. Is this better for audio?
Yes, much better. Thank you.
Okay, thank you. Can you go to the next slide? Okay, I'm just going to start this slide over. Before diving into VE estimates, I wanted to provide a bit of context for interpretation of the results I'll share today. By July to August of 2022, just before the bivalent vaccines were introduced, individuals in the U.S. had high rates of infection-induced immunity, well above 50% for all age groups except those 65 and up, which was just below 50%. Infection can provide some protection from future infection, and VE findings should therefore be interpreted as the incremental benefit provided by COVID-19 vaccination in a population with a high prevalence of infection-induced immunity. Next slide. I'll start today with updates to VE against emergency department and urgent care visits in young children. More detailed methods are available at the citation shown here. Next slide. The Vision Network is a multi-site network based on electronic healthcare records. It uses a test-negative design, and this analysis included immunocompetent children aged 6 months to 4 or 5 years visiting a participating emergency department or urgent care and receiving a NAT test. Cases had COVID-like illness and a positive NAT test, and controls had CLI with a negative NAT. Vaccination is determined via electronic health record and state and city registries. Next slide. This slide shows VE for an original monovalent Moderna primary series in children aged 6 months through 5 years against ED-UC encounters. On the top half of the slide is VE for a single dose administered at least 14 days and a median of 66 days prior. VE was 23% with confidence intervals crossing the null. The bottom half of the slide shows VE of 2 doses of Moderna at least 14 days prior and then split by time since dose, 14 to 59 days and 60 days or more, with median time since dose for each row shown in the second column from the right. Here we see similar patterns to what we've seen previously in older children and adults. VE starts at 46% and wanes, in this case to 24% by a median of 124 days prior. Next slide. This slide has a similar format to the previous slide, now with an original monovalent Pfizer-BioNTech primary series in children aged 6 months through 4 years. The top section again shows a non-significant VE for a single dose. VE of 2 doses, which is an incomplete primary series for Pfizer, was initially 44% but waned to 23% with confidence intervals crossing the null, a median of 111 days after the second dose. The bottom section of the slide shows VE of 3 doses, or a complete primary series for Pfizer, which is similar to that for 2 doses. Note that there were not enough children to precisely estimate VE by time since the 3rd dose. Next slide. Finally, here we have VE for 1 or more bivalent doses of Pfizer and Moderna combined in children aged 6 months through 4 or 5 years, respectively, among children who had completed a primary series of monovalent or bivalent doses. There was not enough data to estimate VE by time since dose, but VE was 61%, a median of 66 days after the bivalent dose. Next slide. 1 dose of original monovalent Moderna or Pfizer-BioNTech vaccines did not provide significant protection in young children. 2 doses of either product and 3 doses of Pfizer-BioNTech provided protection against ED-UC and hospitalization, though waning was evident, similar to older children and adults. A bivalent dose provided protection, though sample size was limited. Of note, the median interval since receipt of the most recent dose among children who had not completed their primary series was longer than expected based on recommended dosing intervals, indicating that some children are not completing the primary series. Next slide. Moving on now to updates to bivalent VE from 2 platforms, Vision and Ivy. More detailed methods are available at the links on this page. Next slide. I won't repeat the main Vision methods since I just went through those a few slides ago, but the analyses here and on the next few slides are in older children, adolescents, and adults, and include emergency department and urgent care visits, as well as hospitalizations and critical illness. Analyses in the following slides go from September 2022 through August 2023, so include Omicron BA4, 5, and XBB predominant periods. Next slide. This slide shows VE of original monovalent and bivalent doses against emergency department and urgent care visits by age group, including older children and adolescents aged 5 to 17, adults aged 18 to 64 years, and adults aged 65 and up. VE is similar across age groups. Next slide. With little protection remaining from monovalent doses shown in orange, which were administered a median of 11 months or more prior to the index ED or UC visit. Next slide. VE of a single bivalent booster dose, shown in magenta, administered 7 to 59 days prior was significantly higher, and again similar across age groups with point estimates between 56 and 63%, with overlapping confidence intervals across the age groups. Next slide. Finally, VE of a bivalent booster dose administered 6 to 119 days prior shows some waning compared to the earlier timeframes, with point estimates again similar across age groups. Next slide. Here we have VE of original monovalent and bivalent doses by time since vaccination against hospitalization among immunocompetent adults. For both age groups, residual protection from the original monovalent vaccine administered a median of over 13 months prior, shown in orange, is low. A bivalent dose, shown in magenta, restored some protection, which then waned in both age groups, with potentially more waning in younger adults, although vaccine uptake in younger adults was low and confidence intervals are wide and somewhat difficult to interpret. Next slide. This slide shows absolute VE of monovalent and bivalent vaccines against hospitalization on the top and critical illness on the bottom, with critical illness defined as admission to the ICU or COVID-19 associated death. Estimates for bivalent VE for both outcomes are shown by time since vaccination in the same increments as on the previous slide. Next slide. Sorry, go back one. As you can see, VE of the monovalent dose, shown here in orange with a median of over 13 months from vaccination, is relatively low. Initially, VE of a bivalent dose, shown in magenta, is high. However, waning is evident against hospitalization on the top. Note that the different pattern against the most critical illness is shown on the bottom. Although VE drops somewhat, it appears more durable at 52%, a median of almost 5 months after the last dose. Next slide. Finally, from vision, this slide shows VE broken down by immunocompromised status. Individuals without immunocompromise are shown on the top, and individuals with immunocompromise are shown on the bottom. VE point estimates are generally lower for those with immunocompromising conditions compared to persons without immunocompromising conditions. The waning pattern is a little less clear in those with immunocompromising conditions, though VE appears lower in the 120 to 179 day group compared to the 7 to 59 day group, though confidence intervals do overlap. The patterns of waning may be less clear in immunocompromised individuals because of heterogeneity in immune response among those with immunocompromising conditions, or because of limited statistical power to detect differences by time. There were not enough cases to estimate VE specifically for different types of immunocompromising conditions, though VE has been shown to vary based on type of condition previously. Next slide. Next slide. Thank you. Moving on now to the Ivy Network, a multi-site VE platform that uses a prospective case control design. For this analysis, participants were from 25 hospitals in 20 states with hospitalization between September 8th, 2022 and May 29th, 2023. Participants are adults hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls are negative for SARS-CoV-2 and influenza by NAT. Vaccination history is ascertained through EMRs, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. The analyses were completed for hospitalizations here from September 2022 through May 2023. Next slide. Here we see monovalent and bivalent VE against hospitalization in immunocompetent adults by time since last bivalent dose. As with vision, VE of a monovalent dose received a median of 412 days prior to hospitalization, shown here in orange, was low. IV data show the same pattern as vision data, with the bivalent VE against hospitalization shown in magenta, decreasing with time since vaccination for both younger and older adults, though note that the confidence interval for 90 to 179 days is quite wide in both groups. Next slide. Finally, from IV, this shows VE broken down by immunocompromised status. We see the same pattern of waning among immunocompetent individuals as previously, with a less clear pattern among those with immunocompromise, though note the wide confidence intervals for those with immunocompromise who were vaccinated 90 to 179 days earlier. Next slide. So in summary, current data from CDC vaccine effectiveness platforms demonstrate that bivalent boosters provided additional protection compared to individuals with distant monovalent doses. Waning of bivalent VE against hospitalization and EDUC visits was evident, though there was more sustained protection against critical illness. It's difficult, however, to separate impact of time since vaccination from emergence of new variants. Next, go back. VE patterns include waning, including waning appear similar across age groups, though low uptake of bivalent doses in younger age groups prevented assessment of waning beyond 4 months from the bivalent dose. Persons with immunocompromise may have reduced protection from COVID-19 vaccination compared with persons without immunocompromise. Historically, COVID-19 VE has been lower and waned more quickly for adults with immunocompromise compared to those without. Trends in bivalent VE, however, were less clear and additional data are needed. Finally, as I mentioned at the beginning of the presentation, VE findings should be interpreted as the incremental benefit provided by COVID-19 vaccine in a population with high prevalence of infection-induced immunity. Next slide. This concludes the presentation, and I want to thank the numerous individuals and teams from both CDC and at the platform study sites for their countless hours ensuring high-quality data and analyses are available to ACIP. Thank you.
Thank you very much. And this set of presentation is now open for questions. Dr. Paling.
First, I want to thank each of the speakers for very clear and helpful presentations on what is transpiring now. My first question is to Dr. Havers. In your presentation about the epidemiology and COVID vaccine hospitalizations, and do you have data on race and ethnicity? Thank you.
We do have data on race and ethnicity. I think if you go to backup slide number 22, I can show that. I think also Dr. Wallace is going to be presenting some data on race and ethnicity in the evidence to recommendation slides. So what I will say is that we have been tracking health disparities throughout the COVID pandemic, and generally speaking, they still remain. But they have perhaps a little bit less than earlier in the pandemic. What the slides up here show the 3-week moving average rate by race and ethnicity from January through August 2023. And then sometimes weekly, and this is the weekly rates with, as you can see, non-Hispanic Black persons, the rates are in blue. American Indian and Alaska Native are shown in yellow, and they currently have the highest cumulative rates, although I will note that the number of American Indian and Alaska Native population within the COVID-19 catchment area is relatively small. If you look at the COVID-19 cumulative rates from the last season, from October 22 to 2023, you can see on the right that rates remain highest in American Indian and Alaska Native populations and non-Hispanic Black populations. We have seen over the last year the gap between Hispanic and non-Hispanic white populations has narrowed a little bit, which is shown in the purple and the black lines there. So we do have data on that. It's also published weekly on our COVID-19 dashboard, so it's publicly available, but I can answer also other specific questions about that.
Thank you. While we're waiting to see if any additional questions arise, I just really quickly, do you have a sense of the vaccination rates as well and whether or not there are disparities in vaccination rates?
I am not the best person to answer that. I think I'm going to defer to Dr. Wallace, who can answer questions on that.
Dr. Wallace, we can come back to that later when you present.
Okay, great. Yes, that's in my presentation.
Thank you. Dr. Sanchez.
Hi, thank you. And again, thank you for the clear presentations. I was wondering, you present, or I guess in one of the presentations, I think it was Dr. Havers, yes, who presented data on high rates of hospitalization among infants less than 6 months. And do you have any data on maternal vaccination in that age group?
We are collecting data at that time. Right now, we don't have any data specifically on those infants who are hospitalized, but that is something that we're looking into, and data collection on maternal vaccination of hospitalized infants is ongoing at the moment. But I apologize, I don't have that available today.
Dr. Paling?
Okay, thank you. I wanted to ask a similar question to Dr. Seda on long COVID. Do we have any differences in long COVID by race and ethnicity? Thank you.
Yes, thank you. That is a good question. I don't have any of that data to present today. We do know that people, because there's been disproportionate impact of COVID-19 by race, ethnicity, and for severity of infection, we would expect that to translate into increased risk for long COVID.
Thank you. Dr. Daly?
Yes, this is a question for Dr. Thornburg. Dr. Thornburg, you mentioned that certain amino acid-based substitutions in the spike might confer survival advantage. And so that made me wonder, to what extent, if any, does vaccination drive virus evolution? Thanks.
Dr. Thornburg, I can see you're unmuted, but we can't hear you yet.
Okay, sorry about that. Was triple muted. So vaccination and infection generate, population immunity, and that population immunity can create bottlenecks for the virus. And so, everybody. How do I say this? Everybody generates very complex, repertoire of monoclonal antibodies. So you have this, hundreds, thousands of different individual antibodies, and everybody has a unique set of antibodies. And it's hard to quantify just how much vaccination drives that very complex repertoire, infection, or a combination thereof. But population immunity in general can absolutely create bottlenecks for a virus. So if 99% of the population has neutralizing antibodies against, a residue 456, then the virus might, can't infect 99% of the population. Therefore, it has to take hold in or change that one residue if it's able to change that one residue. So just in general, antibody repertoires can create bottlenecks for a virus, and a virus that is able to evolve can find ways around that. But it's hard to quantify vaccination versus infection, especially in the face of durability, where just how much antibody any population has at one given time is difficult to quantify.
Thank you. Dr. Brooks?
Yes, thank you. First of all, excellent presentations. I have one question, one comment for Dr. Seda. First, I really appreciate the data on the effect of vaccination and potential reduction of getting long COVID. I've often felt that a major concern is long COVID, which we will be seeing, years after you have the actual infection, or at least a year. So that's significant, and it's excellent data. And the question I had is, there was a slide that showed that 16% have ongoing symptoms after 12 months. I just wanted to clarify whether that was 16% of those that had COVID disease, or 16% of those that had what we'll call long COVID.
Yeah, thank you. So that is that was on slide 7. So that is from a prospective cohort study we had, where we enrolled individuals who all had acute COVID-like symptoms at baseline and then tested positive or negative for COVID-19. And that 16% of those who either tested positive or negative continue to have ongoing symptoms at 12 months from the time of testing.
Thank you, because that's that's 1 in 6. That's pretty significant finding. Thank you.
Thank you. Dr. Paling?
Thank you. My question is for Dr. Link Gellis. You presented great data on COVID-19 vaccine effectiveness in both children and adults in prevention of ED, urgent care, and hospitalization. And I wanted to make sure my interpretation is correct. And what I understood is that the vast majority of persons of all ages have had COVID infection, but having an updated COVID vaccine provides additional protection in preventing ED, urgent care, and hospitalizations and severe illness for the older adults, regardless if you're immunocompromised or not. Is that a correct interpretation? Thank you.
Yes, I believe that's a correct interpretation. I mean, generally, I would say because the bivalent and monovalent, original monovalent vaccines were not authorized at the same time in the US, we can't do sort of a head-to-head comparison of the two. But what we did see was that original monovalent protection had waned quite a bit across age groups and across immunocompromised status. And so the median time since dose for people that did not get a bivalent dose is more than a year for most age groups at this point, so quite a bit out. And so what we saw was that the bivalent booster restored protection that had been lost by the monovalent waning. And then, of course, we do see some waning for the bivalent booster, but we see much more durable protection, both for monovalent and bivalent doses amongst the most critical illness outcomes, so ICU or mechanical ventilation or death.
Dr. Long?
Yes, it's a question for Dr. Havers about the epidemiology of COVID disease and hospitalizations by age, and a special question is about the observation of very high incidence in those under 6 months and under 23 months. And the question is, I believe you referred to it all as COVID. And I assume that I think of COVID as COVID lung disease, as is characteristic in adults and older and obese teenagers. I assume this was not lung disease, but these were hospitalizations mainly for something else like fever or sick don't know why, or suspicion of or occurrence of MIS-C. Is that correct? Do you have any ballpark numbers or percents of those young children admitted to the hospital with COVID, of what the clinical syndrome was?
Yeah, no, thank you for that question. I hope you can hear me now. We do have data on that. We collect symptoms on all of when we do the medical chart review. I would say that the vast majority of children under 5 presented with respiratory symptoms who were admitted with a positive SARS-CoV-2 test. And I will say that the data that I think that most children are having respiratory symptoms. Some of them are being admitted with fever and other things. I don't have a breakdown of symptoms on the slides here, but I'm happy to provide that after. We do collect those data. I would say, generally speaking, respiratory symptoms such as cough, fever, shortness of breath, and then also symptoms like bronchiolitis in younger children are fairly common, but I don't have a breakdown on these slides here. But I think that most of the children that we're talking about here today, including among young infants, do have respiratory symptoms.
And do you believe that of the deaths among children, that the vast majority had COVID-like lung disease rather than the other syndromes that children usually have, younger children have with coronavirus infection?
I haven't looked specifically at the symptoms among the children that died within COVIDnet in the COVIDnet catchment area, but that's something that we can look into and potentially provide at a later date. I think we have looked at this at other times, like earlier in the pandemic, and we were seeing that a significant proportion of them had respiratory symptoms, but I don't have that data on hand for those specifically who had in-hospital death.
Thank you, Dr. Lair.
Thank you. Could we go to Dr. Sada's slides, please? On slide 4, there's a number of 9% in the middle age groups for the prevalence of symptoms. And then on slide 7, 3 slides further out, it says that this decreases, but that 16% of people still had symptoms at 12 months. I'm just trying to reconcile those two things. Did it go up from 9% down? Because I just want to get a sense of, is it more close to 10%, more close to a quarter of people have symptoms?
Thank
you.
It's a good question. It's one of the challenges we have with studying post-COVID conditions. There are multiple approaches to studying this question, and multiple studies will give you slightly different answers. So what is presented in Slide 4 is from our National Health Interview Survey. So this is among all U.S. adults as the denominator, and then the numerator for these estimates is report of for the 9% ever experiencing long COVID, so that's symptoms lasting 3 months or longer. And then that 4.7% in the same 30 to 49-year age group is for those currently reporting long COVID. And then on slide, that next slide that you were referring to on slide, there we go, on slide 7, the 16% was in a prospective cohort study that we had, so that was not representative of the U.S. population. It was among 6,000 individuals who either tested positive or negative for COVID-19 who had acute COVID-19-like symptoms. So it's a different population. The main point here is just that a significant portion of them continued to experience ongoing symptoms at 12 months.
So I'm sorry to ask, but I get asked by patients, if you get COVID, what is your chance of having long COVID at, let's say, 6 months? Are we talking about 1 in 10, 1 in 4? Do you have any sense of that?
I will give you the answer of I think it depends on a number of other factors, right? So all the different things that we have in slide 8 that are corresponding to your likelihood of developing long COVID. So based on your age, severity of the acute COVID-19 illness, whether you have any underlying conditions, and whether or not you've been vaccinated would be some of those factors that would play into that. We don't necessarily have that risk calculation for at the individual patient level on the likelihood of developing long COVID.
Thank you.
Thank you. I'm just going to wrap up this part of the session. I'm just going to acknowledge we're also very far behind, but I wanted to make a few comments for the team to consider. One is that I know that my colleagues and I are very appreciative that we're still collecting epidemiology information as well as, viral variant information, in part because we recognize that COVID is a dynamic infection that's going to change over time, and being able to continue to monitor the ongoing benefit risk balance is going to be very important for this committee and for the public. So again, really appreciate the ongoing infrastructure support for the systems that are able to collect this information. I do think, we did hear a call or a request for continued visibility on disparities and making sure that we are keeping health equities at the center of many of our activities. So we'll just request that going forward. We continue to include that, be inclusive of that information in these presentations. The second thing I did want to just highlight is that while there were no high-risk conditions that were needed for hospitalization, so it's surprisingly a large number of children, particularly young children, didn't have any high-risk conditions. I do think additional clarity around some of the neurologic conditions, because that's a very broad term, it would be really helpful, particularly children versus adults, and just understanding or unpacking that further, as well as Dr. Long mentioned, just having more information, and particularly in children, around some of the information around in-hospital deaths. And then the final thing I just, wanted to highlight and recognize is that this is the first time I can remember that we're talking about a respiratory viral vaccine that can potentially prevent both acute and chronic illness. And so this is different than how I usually think about it. But thank you for continuing to capture information on long COVID. I think it's really important for our patients and families and the populations to have this information available. And again, a plea for just being able to communicate per Dr. Lehrer's request, how we can support our families in their decision-making for their kids and for themselves. And with that, I'm going to actually move us along to the economic analysis of COVID-19 vaccines by Dr. Lisa Prosser.
Great, thank you, Dr. Lee. Good morning, everyone. I'm Lisa Prosser, and I'll be reviewing initial results of the economic analysis of an mRNA booster to prevent COVID-19 illness in adults. Next slide, please. I'd like to start by acknowledging our research team, which includes collaborators from CDC and the University of Michigan, who have worked countless hours to contribute to this modeling analysis. Next slide, please. We do not have any conflicts to report. Next slide. The objectives of this study were to first estimate the annual disease burden and healthcare utilization associated with COVID-19 illness and COVID-19 booster vaccination, including cases of symptomatic illness, hospitalizations, deaths, adverse events, costs, and quality-adjusted life years. And second, to project the cost effectiveness of an updated mRNA booster against COVID-19 associated illness in persons ages 18 and older. Next slide. The intervention strategies included in the analysis were vaccination against COVID-19 illness with an updated generic mRNA booster, compared with no updated mRNA booster, that is vaccination against COVID-19 illness of primary series only or primary series plus current booster. The target population included all U.S. adults stratified by age into the following age groups: 18 to 49 years, 50 to 64 years, and 65 and older. Pediatric and adolescent age groups are excluded from the current analysis. There were insufficient data to incorporate these age groups into this first phase analysis, and these will be incorporated into later analyses as more data become available. Time horizon for the analysis is 1 year, with costs and qualities lost due to long-term sequelae and deaths beyond 1 year accounted for. The analysis uses a societal perspective with a costing year of 2023 and a discount rate of 3%. Next slide. We use simulation modeling to project costs and health outcomes for each age group. This slide shows a simplified schematic of the simulation model. In the model, an individual has some probability of remaining disease-free or experiencing COVID-19 illness. If they experience COVID-19 illness, they can have an episode of non-hospitalized COVID-19 illness or become hospitalized due to COVID-19. Symptomatic illness can also incur an outpatient or ED visit. If hospitalized, the severity of illness can require ICU care or ventilator assistance. All individuals who experience COVID-19 illness are at risk for long COVID. Hospitalized patients also have probabilities of long-term permanent sequelae or dying from COVID-19. As simulated individuals travel through the model, they accumulate costs and loss in quality of life associated with each health state. Also included in the model are adverse events associated with vaccination, including systemic reactions, anaphylaxis, and myocarditis. These events are also associated with costs and loss of quality of life, depending on the severity of the adverse event. Each probability, cost, and quality adjustment is represented by a most likely value and a range of plausible parameter values. Identical cohorts are run through the two submodels, one in which all individuals in the cohort receive a booster dose and one in which they do not. Next slide, please. The analysis is designed to project disaggregated health and economic outcomes stratified by intervention strategy and by age subgroups, including cases, hospitalizations, deaths, costs, and quality-adjusted life years. Incremental cost-effectiveness ratios in dollars per quality are calculated, comparing updated mRNA booster to no booster. This metric measures the additional investment in vaccination, or cost savings, associated with a change in health benefits.
There you go. Hello. There you go.
Hello, can you hear me?
Our colleagues from Pfizer, could you please mute? Thank you.
Okay. Are you able to hear me? Okay, great.
Yes.
So this metric measures the additional investment in vaccination or cost savings associated with a change in health benefits and accounts for offsets due to averted illness. We also conducted a set of uncertainty analyses, one-way sensitivity and scenario analyses to explore the robustness of the results to changes in input parameters. It's important to note that this presentation reports preliminary results only from the first phase of an ongoing analysis. Next slide, please. In the next slides, I'll briefly present the key inputs into the model. Most parameters rely on unpublished data, which best reflects the current evidence base for COVID-19 illness and the effectiveness of an mRNA booster. Next slide, please. The probability of symptomatic infection is based on the last 6 months of available data from the HEROES Recover cohort, shown on the left-hand side of the slide, assuming that rates from the most recent 6-month period available would serve as a reasonable proxy for predicting future rates of symptomatic illness. These are translated into annual probabilities stratified by age group and shown in the table on the right. Next slide, please. This slide shows the same probabilities of symptomatic infection from the previous slide, along with associated ranges. Upper and lower bounds were derived from the months with lowest and highest rates of symptomatic infection in the last 6 months and varied more widely in scenario analyses. Next slide, please. This slide shows the probability of an outpatient visit due to COVID-19 derived from Meredith Market Scan data. Again, the last 6 months of data are used. Note this is an earlier time frame than the COVID-19 data or the previous data that we saw from the Heroes Recover cohort. Next slide, please. The probability of an outpatient or D visit from the market scan data are combined with the probability of symptomatic infection from the Heroes Recover data using a common time period to derive a conditional probability of outpatient visit or ED visit given symptomatic illness. Both probabilities increase with age and associated ranges are listed in the table. Next slide, please. The annual probability of hospitalization is also derived using the last 6 months of data, this time from the COVID-19 data set. Probabilities and associated ranges are shown on the table on the right. Probabilities increase with age. The lower panel simply translates these into rates per 100,000 individuals. Next slide, please. The probabilities of requiring ICU care or ventilator assistance are also derived from COVID-19 data and vary with age as shown here. Next slide. The probability of dying from COVID-19 depends on the severity of illness, increasing both with severity of illness and with age. Again, these parameters are based on unpublished COVID-19 data. Next slide. Parameters relating to long COVID in the model assume a median duration of 5 months of symptoms. The base case probability as shown here is estimated at 7.2% with a range of 5.8 to 9.1%. The evidence base reflecting the discussion that just occurred is even less robust than for other endpoints. And although the risk of long COVID is almost certainly associated with both age and severity of illness, these associations are not yet incorporated into the model and will be updated as more data become available. Next slide. In the next few slides, I'll review the approach used to estimate vaccine effectiveness for an mRNA booster. Vaccination-related adverse events are also accounted for in the model. Next slide. The panel on the left shows data on effectiveness against hospitalization for the bivalent booster from the VISION study by interval days since last dose. Using data available for 180 days, 3 scenarios were used to extend the vaccine effectiveness to 1 year. An optimistic scenario, which assumes the VE observed in the last period remained for the duration of the year, a conservative scenario in which VE waned to 0 beyond 180 days, and a midpoint scenario which assumed linear waning from 180 days until the end of the year. Next slide. Using the same approach, we derived annual waning function for the bivalent booster using data from the IV study. Next slide. Combining data from the VISION and IV studies, we calculated the area under the curve to estimate annual VE for an mRNA booster as shown in the bottom panel. Next slide. This slide summarizes the AUCs for the conservative and optimistic scenarios for each of the VISION and IV studies. The minimum of the conservative estimates and maximum of the optimistic estimates were selected for the lower and upper bounds for VE, and the base case VE is shown in the bottom row in this table. Again, this is against hospitalization. Next slide, please. A similar approach was used to derive VE for critical illness using VISION and IV data. This is a combined endpoint that includes both ICU care and deaths. This VE is then applied to both of these endpoints in the model. Additional uncertainty analyses are conducted for VE to reflect the uncertainty in the underlying evidence base. Next slide. Data were unavailable to inform VE against symptomatic illness. An assumption was made to apply the same VE for uncomplicated hospitalization to symptomatic illness. And sufficient data were not available to evaluate possible variation by VE by age group. Next slide, please. The probabilities of adverse events were included in the analysis as shown here for systemic reactions, anaphylaxis, and myocarditis. A very small probability of dying due to vaccine-associated anaphylaxis or myocarditis is also included in the model. These parameters are informed by FDA fact sheets, published data, and expert opinion. Next slide. The model also includes direct medical costs and productivity losses associated with lost time from work and other productive activities due to illness or vaccination-related adverse events. Next slide. This table lists the costs associated with testing for non-medically attended symptomatic illness, as well as those for an outpatient visit. It's assumed that testing costs for illnesses incurred associated with an outpatient visit are included in the costs of the outpatient visit. So these are only included separately for the symptomatic illnesses which are not medically attended. Again, the costs of long COVID reflect a median duration of a 5-month episode. Outpatient costs and costs associated with long COVID were estimated using market scan data. Next slide, please. Costs of hospitalization were also derived from market scan data. These costs vary by age and by severity of illness episode. Post-hospitalization costs within 1 year, as well as costs of long-term permanent sequelae following hospitalization, are also included for a small proportion of patients post-ICU. Next slide. A small cost was included for over-the-counter medications for symptomatic illness that was not hospitalized. An outpatient visit may also include a prescription for nirmatrelvir. The probability of receiving a prescription increases with age. Next slide, please. The costs of vaccination include costs of the booster dose, administration costs, and time costs for the vaccine recipient. Time costs vary by setting and assume a proportion of vaccinations vary across setting based on recent survey data. The cost of a booster dose is set to $120 in the base case and varied from $30 to $200. Next slide. Costs of vaccination-associated adverse events are also included in the analysis and reflect both direct medical costs as well as productivity losses. Next slide. The effects of COVID-19 illness and vaccine-associated adverse events are incorporated into the model as losses in quality-adjusted life years. One quality-adjusted life year can be thought of as the equivalent of living for 1 year in perfect health. Next slide. This slide shows quality losses for COVID-19 related illness. These values are based on responses to the EQ5DA generic utility instrument, which was incorporated into longitudinal surveys implemented by CDC and supplemented with data from 2 additional CDC Michigan health preference surveys fielded over the last several years. The second to last column here translates these into quality adjusted life days lost for easier interpretation. The quality of life impacts of long-term sequelae for post-hospitalization are also included, not shown here. Next slide. Quality adjustments for vaccination-associated adverse events are based on published values and expert opinion. Next slide. In the next set of slides, I'll review the preliminary results from the first phase of modeling. Next slide. This slide shows disaggregated results for projected cases, hospitalizations, ICU stays, and deaths. The left-hand panel lists projected numbers for each strategy, booster vaccination or not, stratified by age group. Results are presented for cohorts of 100,000. The right-hand side of the table lists numbers of cases averted by vaccination, with higher numbers of cases averted for all endpoints for older age groups. Next slide. This slide reports incremental cost-effectiveness ratios, or ICERs, for each age group using a societal perspective. For 18 to 49 and for 50 to 64-year-olds, vaccination requires an additional investment, as shown in the incremental cost column, and yields additional health benefits as measured by an increase in qualities. The resulting ICERs are roughly $116,000 per quality for 18 to 49-year-olds and $26,000 per quality for 50 to 64-year-olds. For the 65 years and older age group, booster vaccination results in cost savings and also yields additional health benefits as measured in additional quality-adjusted life years. Next slide, please. Considering the cost effectiveness of all individuals ages 18 and older together yields an ICER of roughly $33,000 per quality, as shown in the bottom row of this table. Next slide. The next few slides present uncertainty analyses as input parameters are varied from their original base case values. This tornado diagram displays one-way sensitivity analyses for the most influential parameters in the analysis for the 18 to 49-year age group. Results were most sensitive to the cost per booster dose, which was varied here from 30 to 200, and yielded ICERs from $13,000 per quality to more than $200,000 per quality. I'd like to highlight that 3 of the variables that are the most influential in the analysis relate to VE, and we will explore some additional scenario analyses on the next slide. And a quick note that the variable at the bottom of the list is the probability of symptomatic illness non-hospitalized and independent from conditional probability of hospitalization. Overall, the results are sensitive to changes in these input parameters. Not shown here are the one-way sensitivity analyses for the older age groups. These analyses are more robust to changes in the input parameters, with ICERs varying up to about $84,000 per quality for 50 to 64-year-olds and up to $10,000 per quality for 65 and older. Next slide, please. We ran a number of scenarios to explore the impact of vaccine effectiveness. The first column represents base case values. Scenario 1 and Scenario 2 set VE first to all lower or to all upper bounds. Scenario 4 applies the VE for uncomplicated hospitalization to all endpoints, and Scenario 5 applies the VE against critical illness to all endpoints. Results are very sensitive to changes in VE for the 18 to 49 year age group. The results for the 50 to 64 age group are robust to changes except for Scenario 1. And finally, results in the 65 and older age group are not very sensitive to changes in VE. Next slide, please. Varying the probability of symptomatic illness is also very influential for the 18 to 49 age group. A reminder that the base case probability of symptomatic illness ranges from 28 to 33% and varies by age. Varying this probability for older age groups yields smaller changes in the ICERs. Next slide. Varying the probability of hospitalization from 2 to 4 times the base case, a very rough proxy for high-risk individuals, yields substantially more favorable cost-effectiveness ratios across all age groups and cost saving in many scenarios. Next slide, please. Another scenario analysis of higher risk for critical illness also yields more favorable ratios, cost saving for ages 50 and older. Next slide. Evaluating the change in cost effectiveness of vaccinations delivered in different types of settings with different associated cost structures has less of an effect on the ICERs. Next slide. This analysis includes some limitations. Unpublished data were used to derive key parameters in the model: vaccine effectiveness, symptomatic illness, probabilities of hospitalization, and critical illness. Data sources vary in representativeness and generalizability. Market scan data includes only those for supplemental insurance for individuals older 65 and may underestimate costs in those age groups. The VE estimates were derived from data on bivalent booster, for which we had interval days since last dose. The evidence base for long COVID is especially scarce. Future analyses will incorporate adjustments to reflect differences in probability and duration of long COVID by age and severity of illness. Next slide, please. In summary, vaccination averts substantial morbidity and mortality as demonstrated through estimated disaggregated outcomes. The ICERs for 50 to 64-year-olds and 65 and older age groups are robust to changes in parameter inputs across plausible ranges in all but one scenario. Incremental cost effectiveness ratios for 18 to 49-year-olds are sensitive to changes in parameter inputs and more favorable for higher VE, higher risk of hospitalization, and critical illness. This concludes this presentation, and I look forward to taking questions later in the session. Thank you.
Thank you so much, Dr. Prosser. And we will take questions after the next presentation. So please make sure you're logging them in. We'll move on to COVID-19 vaccine safety surveillance with Dr. Nikki Klein.
Good morning. Thank you for the chance to present really what will be a summary of the last several years of work from the Vaccine Safety Data Link. Next slide. So the Vaccine Safety Data Link, and I just want to, that's what I'll be focusing today on exclusively, but I just want to mention that it is not the only safety system in the United States. But just to take a minute just to talk about overall what we do is active surveillance, which is for newly licensed vaccines, and that's rapid cycle analysis, which you'll be hearing about extensively today. But I also just want to point out that there are other functions of the Vaccine Safety Data Link, including evaluating vaccine safety of new recommendations for existing vaccines or vaccines for high-risk populations, to develop new methods in vaccine safety assessment, and to test hypotheses that emerge from elsewhere, such as in VAERS or clinical trials. Next slide, please. So focusing, as I mentioned, on the strength of the VSD's rapid cycle analysis, or RCA. So the population is approximately 12.5 million people for all the studies I'll be showing you, which is equal to approximately 4% of the US population across VSD data sites, which are geographically and racially diverse. The data is near real-time data with analyses updated weekly. We have access to comprehensive medical records, including vaccinations and outcomes, and we can do rapid chart reviews to obtain additional clinical information as needed. There's also, we have been able to employ innovative methods, including the vaccinated concurrent comparators, which you will hear about extensively today. And for these in which recent vaccinees who are beyond their risk interval are expected to be similar to current vaccinees who are within their risk interval. We think they serve as better comparators than unvaccinated individuals, historical controls, or non-concurrent self-controls because they allow for careful adjustment of potential biases, associate calendar time, site, and demographic factors. And we're also able to begin them sooner than other alternative methods. But in addition, we also did a lot of supplemental analyses, which were conducted weekly, and mostly those were unvaccinated and unboosted comparators that were available as needed in real time. Next slide, please. So focusing on today on the COVID-19 vaccine RCA, I think I've shown this many times before, but the aims were to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest among VSD members. And we also describe the uptake over time of COVID-19 vaccines. We began surveillance in December 2020, and we began when the first doses of COVID-19 vaccines were given. Next slide. So I just want to take a minute to talk about the outcomes that we did monitor, 23 serious outcomes. And the outcomes that were chosen were actually chosen because of really 4 main reasons. Either they were included in prior vaccine safety studies, and they're typically or almost always studied for vaccine safety, including the ones you see listed here. There were hypothetical concerns regarding an association with COVID-19 disease. Those are listed, you can see listed below. We also included outcomes, we added outcomes during the course of surveillance that were either added or enhanced due to emerging concerns. And then finally, there are any imbalances in the phase 3 clinical trials, vaccine trials were included as outcomes. Now those outcomes in red were only monitored without comparators. And then finally, those with the green check mark, we only used chart confirmed cases in our analyses. Next slide, please. So here is a picture. I think most of you have seen this. So this really shows our method. This is the vaccinee for the example case is an outcome of myocarditis. This would apply to all the outcomes, however. But this is, for example, shows vaccinees with myocarditis in a risk interval and a concurrent comparator for the vaccinated concurrent comparators. On the top panel, importantly, so on each calendar day, these are anchored on calendar day, an outcome that occurred in a vaccinee, and in this case, it happened to be on June 3rd, was compared to the vaccinee. They were vaccinating their risk interval because they were in their risk interval 1 to 21 days because they were vaccinated May 30th. Now, they were compared to, on June 3rd, a comparator who were in the comparison interval because they had been vaccinated, for example, on May 3rd. And so by similar, we mean they're in the same age group and at the same sex, race, and at the same VSD site. And so this is the analytic framework that for nearly all the analysis I will be showing you for the rest of the presentation, unless I state otherwise. But for the most part, this will be the analysis for all of them. Next slide, please. So this is an overview of what has, not everything, but many things that have happened in this safety monitoring for the last 3 years. This is a very busy slide, and I will go through it slowly, but this is the overview right here. So, next slide. So I'm going to start right now. This is our initial surveillance that really spoke to what I really showed you as the initial aims that I showed you in earlier slides. And this was some interim findings that was of our initial safety surveillance that was published just over 2 years ago, actually now. Next slide. So from this analysis, these are the results using the vaccinated concurrent comparators. Next slide. So this is a busy table that really shows all the outcomes we monitored. I won't go through this one by one, but if you go to the next slide. As an example, you can see this here is a Bell's palsy. And you can see if you look at the middle columns that the rate ratio was 1 and that the confidence intervals really was clustered around 1 with a p-value of one side p-value of 0.52, and that importantly, there was no signal. Now, what's almost more important than that is if you take a look at all the outcomes in that same column, you can see that none of the outcomes signaled. So next slide. And we also included in this initial analysis outcomes without comparators. Next slide. So in this case in particular, we're focusing a lot on anaphylaxis. And what you can see here is when we actually looked at confirmed anaphylaxis cases that were confirmed by medical record review, there were approximately 5 cases per million for both Pfizer and Moderna, and that's per million doses you can see there. Next slide. So as part of this, we also had some outcomes monitored during emerging concerns. Next slide. So I'm going to show here myocarditis and pericarditis, which was started to emerge in mid or early spring 2021. Next slide. So we did some enhanced surveillance for this outcome, and as we were always monitoring this outcome, but once we heard these reports, we started doing enhanced surveillance. Next slide. Which, sorry, this is the reports from from across the world that we were seeing. Next slide. So our enhanced surveillance included chart reviews, which began in May 2021 and included all individuals under the age of 40. So in this case, we identified cases of myocarditis and pericarditis during the 98 days after vaccination were chart reviewed, followed by infectious disease clinician and or cardiologist adjudication to confirm the case. Next slide. And when we looked at the clustering of the cases after vaccination, what we could see, this is amongst confirmed cases by day since most recent dose of any mRNA vaccine among 12 to 39-year-olds. And what is really quite clear and can be shown statistically, but you can see it right there, is that there's a very strong and sharp peak of cases within the first week after the vaccination. Next slide. And in fact, you can see this here when we did analyses of the 0 to 7 days, and this is again the vaccinated concurrent comparator analysis, but focusing on the 0 to 7 days after dose 2, for example. Unlike what I showed you earlier with Bell's palsy example, you can see the adjusted rate ratio in this population of 12 to 39-year-olds, we had an adjusted rate ratio of 10.4 that was highly statistically significant. Next slide. So to summarize that findings, this was good data through June 2021. There were no safety signals for any outcome in the 21 days after both mRNA doses in the overall VSD population of over age 12 years and older. In the subgroup of age 12 to 39-year-olds, the rate ratio for myocarditis and pericarditis was elevated after both Pfizer and Moderna during days 0 to 21 after vaccination, especially during days 0 to 7. In the subgroup analysis, both mRNA vaccines were associated with myocarditis and pericarditis in 12 to 39-year-olds. In the VSD, rate of anaphylaxis after mRNA vaccines was approximately 5 cases per million doses. And of course, VSD surveillance was ongoing at that point. Next slide. So here you can see that, of course, after this was published, we certainly continued to do much more work within the myocarditis and pericarditis because this was really an ongoing concern. So next slide. I do just want to mention that as of August 2021, 2 months after the data from what I showed you, we did actually signal for myocarditis and pericarditis in the 1 to 21 day interval for the population of 12 years and over. So next slide. So as I mentioned, we continue to do more investigations. And in this study, we assessed whether the risk of myocarditis and pericarditis after Moderna differed from that after Pfizer. And so we conducted both indirect and direct head-to-head comparisons among 18 to 39-year-olds. And we limited to 18 and above because 18 to 39, because Moderna at that point was not authorized for under 18. Next slide. So here, what this is again, the vaccinated concurrent comparators, but they're also been separated by vaccine type. Next slide. And you can see here for both Pfizer and Moderna at dose 2, if you look at the adjusted rate ratio, they're both elevated, 14.3 for Pfizer and nearly 18.8 for Moderna. And so the question is that was one for Moderna a little bit higher than Pfizer? It's not clear, but next slide. We did a head-to-head comparison of Moderna versus Pfizer. And again, we were looking at myocarditis and pericarditis during those days 0 to 7, post-vaccination in 18 to 39-year-olds. And when we look at both doses, we could see the adjusted rate ratio is 1.61. It was statistically significant. You can see. And so, however, it wasn't nearly as striking as what we've seen before, but what we can see here is that risk estimates for myocarditis and pericarditis in 18 to 39-year-olds during days 0 to 7 after 2 doses was modestly higher after Moderna than after Pfizer. Next slide. So we also did some additional investigations, really just to really more clearly define the incidence rates. I think that we had a lot of questions, and I think this is, really be helpful for a lot of clinicians. I think a lot of patients come to them asking for these kinds of information. And we wanted to give the rates for verified myocarditis and pericarditis in the 0 to 7 days after mRNA vaccine. And this does include 5 to 39-year-olds in this publication. And so what you can see here is the highest incidence rates per million doses were after dose 2 for the 12 to 15-year-olds and 16 to 17-year-olds. Now, I'm also going to jump ahead a little bit and also say that we also saw the highest rates after the first booster in the 16 to 17-year-olds. Again, these are confirmed cases after 1 million doses. So next slide, please. So moving on through 2021, in July of 2021, the FDA issued safety warnings regarding Guillain-Barré syndrome and Janssen vaccine. I won't go into great detail. We did do some work on this, and I'll just summarize in the next slide. Next slide, please. So the summary of some of the Guillain-Barré work after COVID-19 vaccination, the VSD that we did, was that we found that there were findings that were consistent with an association between increased risk of GBS and Janssen COVID-19 vaccines. You can see the reference there if you're interested. When directly compared with mRNA vaccines, the risk of GBS after Janssen vaccine is 21 times higher. We found no evidence of association between GBS and mRNA-based COVID-19 vaccines. The incidence of GBS in the 21 days after mRNA vaccines was similar to the expected background rate, and there were no statistical signals in the weekly surveillance of the vaccinated concurrent comparators. And just a note, since publication through February 2023, VSD did identify 5 additional confirmed cases of GBS, 4 after mRNA and 1 after Janssen. You can see the details below. And then finally, an ACIP preferentially recommended mRNA-based COVID-19 vaccines over Janssen in December 2021. And then as of this past June 2023, the FDA did revoke Janssen's EUA. Next slide. So moving on through 2021 into the monovalent boosters in September, October, and focusing first on the adult monovalent boosters. Next slide. You can see the uptake for the monovalent booster among 12 and up in the VSD, and you can see a very sharp uptake, which quite quickly fell off and have stayed fairly low since then. And you can see the number of doses given on the right. Next slide. So what we can see here is in the RCA, when we did the RCA vaccinated concurrent comparator analysis, what we saw probably most notably was that for individuals who had mRNA vaccines as the primary and then received an mRNA for their booster, and these are all just mRNA boosters, myocarditis and pericarditis did signal. We also noted a signal for individuals who had received Janssen previously and then received the mRNA booster for Bell's palsy. But the take home of this was following the mRNA primary and monovalent boosters, only myocarditis and pericarditis met the signaling criteria in the 21 days among 12 and up in the VSD. Next slide. So this here is the analysis in which we actually did the vaccinated concurrent comparator analysis of monovalent boosters in 12 to 39-year-olds during the 0 to 7 days. And so what you can see that when you look at both the 12 to 17-year-olds as well as the 18 to 39 who received monovalent boosters, we do see an elevated rate ratio for these different age groups for the different monovalent boosters, although not notably as high as we saw after this dose 2. Next slide. So moving on to later the year, there was an EUA that was authorized for Pfizer for 5 to 11-year-old children. Next slide. So when we looked at the primary series uptake among 5 to 11-year-olds in the VSD, you can see again a rapid uptake, which quite rapidly also fell down and has stayed low throughout the remaining of the surveillance period. Next slide. So we did, again, the vaccinated concurrent comparator analysis in this 5 to 11-year-old population. What we did not see any signals in this population, and there is no outcomes met the signaling criteria. In particular, myocarditis and pericarditis did not signal in the 5 to 11-year-olds in the 1 to 21 day risk interval after the primary series. Next slide. And this was incorporated in this overall safety publication that came out of the CDC Immunization Safety Office. Next slide. So in May of that year, 5 to 11-year-olds were authorized for a monovalent booster. Next slide. So again, you can see that we started, again, the same pattern we've been seeing in terms of uptake in this population. However, if you note the y-axis that the numbers are much lower and the uptake was much lower than we'd seen in previous doses. Next slide. For those outcomes that we were able to do an analysis, none of them signaled for this. This is the monovalent booster for the 5 to 11-year-olds. Again, the vaccinated concurrent comparators, and there were no outcomes, no outcome met the signaling criteria. However, as I noted, vaccine uptake was low. Next slide. Now, all in the background, while all of these different sub-analysis and different analysis and groups were being done, we were continuing to do the overall safety weekly analysis for the primary series for 12 and up. Next slide. So this is just to give you an overall, at the end of the day, the most takeaway for the primary series uptake among age 12 and over was just over 15.7 million doses total. Next slide. And this is the final analysis for the RCA findings in the 1 to 21 day risk interval after the primary series and 12 and up, again, vaccinated concurrent comparator analyses. And what we found was that, what we saw was that, as I mentioned earlier, that there's myocarditis, pericarditis signaled for both the Pfizer as well as both mRNA vaccines. We also saw signals for those two for the acute myocardial infarctions, as well as venous thromboembolisms after those two in both doses. Next slide. Now, at this point, there had been an authorization for Pfizer and Moderna for the 6 months for the youngest children, and these were the priority because the primary series weren't actually being given anymore at this point. So we did some safety follow monitoring in this population. Next slide. You can see the uptake, again, as I've been showing you, again, the uptake has not been very high, and you can see quick uptake, the rate quite quickly fell off and has remained quite low since then. Next slide. Okay, so this is the RCA for the 6 months to 4 to 5 year olds in the 1 to 21 day risk interval. Again, vaccinated concurrent comparator analysis. And this is a busy slide. Next slide, please. But what the take-home message from these results, which we were published a few months ago in June of this year, in which we found that among children 6 months to 4 to 5 years, no outcome met the signaling criteria in the 21 days after primary series. There were no cases of myocarditis or pericarditis within the risk interval. And as I mentioned, vaccine uptake has been low. Next slide. So moving on to the bivalent boosters in mid-2022 last year. Next slide, please. So this is the bivalent booster uptake among persons aged 12 and up over time. So what you can see here is, again, we saw, as we've always been seeing, fairly rapid uptake. But in this case, we had quite a bit more Pfizer than Moderna available due to distribution issues, and what we can see in the red, those are the Pfizer vaccines for the all population. Next slide. So this is, again, a busy slide, but this is the RCA findings in the 1 to 21 day risk interval after the bivalent booster for individuals 6 months to 64 years of age, the vaccinated concurrent comparator analysis. And really what this is showing is that among ages 5 to 64 years in the VSD, no outcomes met the signaling criteria in the 21 days after the bivalent booster dose. Next slide. And this is just to put one more. We did continue to do chart review any cases of myocarditis and pericarditis, and these are the incidence rates of verified myocarditis and pericarditis in the 0 to 7 days after the bivalent booster in 12 to 39 year olds. And what you can see here, there are few cases, and for those that were the incidence rates were calculated, you can see that the confidence intervals were very wide. However, again, it has to be noted that uptake in this age group that is most at greatest risk of myocarditis and pericarditis was low. So we have no evidence that there's increase, but the uptake was low. Next slide. So moving on to what we did find was really our first signal that we saw in real time was the ischemic stroke after bivalent booster greater than 65. Next slide. And talking more about that, the ischemic stroke following Pfizer bivalent booster in 65 years and older. Next slide. So this here is the same slide. The red and blue are the same slide I showed you earlier, but the uptake graph for the bivalent booster, with the exception this is limited to just 65 years and over. But what's also been added is the green line, which is all flu vaccines. So you can see that there's really just those events were happening in real time concomitantly at the same, over time at the same, these doses were being administered in this age population. So next slide. So when we did our vaccinated concurrent comparator RCA in the 1 to 21 day risk interval after the bivalent booster, again, only among over 65, we did see a signal for ischemic stroke after the Pfizer vaccine in the BSD. Next slide. So spend a little more time talking about that. We really first saw a sustained signal in November of 2022. That's as shown in the red dot. And we saw that for, I believe it was 8 weeks. So towards the end, it was a little more intermittently, but we did have a sustained signal for ischemic stroke after the Pfizer bivalent booster among 65 and over. Starting in early February, however, it did attenuate, and it has stayed attenuated since then, as of this last data, which is through March 18th, and it remained attenuated. Next slide. Now, this is the ischemic stroke by day after Pfizer vaccine booster amongst 65. This is by day after vaccination. And this right here is data as of late February, when the signal had attenuated. Now, we do see a cluster. It's not very obvious, but we do see a cluster. It's not statistically significant. But I will say that when we were getting a signal, we were getting statistically significant temporal clustering around days 13 to 22, although it never was nearly as clear cut as what we saw consistently for myocarditis and pericarditis. It's always been a little bit more nuanced and a little bit harder to interpret. Next slide. So what we did also do some post-signal analysis in which we looked at ischemic stroke incidence during days 1 to 21 compared with days 22 to 42. This is a little bit different, not the vaccinated concurrent comparator. It's more of a self-controlled risk interval among 65 years with and without simultaneous influenza vaccine. And so when we look at individuals who receive both Pfizer and the same day high dose or adjuvanted, although most were high dose flu vaccines, we see an adjusted rate ratio when you're comparing cases in the risk interval with cases in the comparison interval of 1.59, which just missed statistical significance. When we look at bivalent Pfizer without any same day flu vaccine, again, comparing cases in the risk and the comparison interval, we see an adjusted rate ratio of 1.82. This is not statistically significant. So all these data together, unfortunately, unlike what we often will see, do not actually yield a real clear answer. And it's a little more complex and a little bit hard to interpret, but nonetheless, next slide. These preliminary results were shared publicly by the CDC and FDA back in January of this year, and this was posted available as a release. So next slide. When we have some additional considerations for the stroke outcome, I think that's something that's very important to think about. What is a complicated and not such a clear-cut answer is that there were small numbers of strokes and imprecise rate ratios, which limited some analyses. The uptake of Moderna booster was delayed and reduced to distribution delays. And the follow-up of individuals who concurrently got bivalent and high-dose or adjuvanted flu was limited by small numbers. I think this was important that it was difficult to interpret temporal clustering, which attenuated as the rate ratio attenuated. Of course, there's possible unmeasured confounding, and the results may be influenced by confounders that vary over time. And then one thing we were unable to really determine was the possible role of SARS-CoV-2 infection before the booster, because the background incidence of SARS-CoV-2 infection was rapidly changing during the bivalent booster uptake period. Next slide. So this is a summary of all of that overview. A high-level overview I just went through. So for anaphylaxis, the rate of anaphylaxis was approximately 5 cases per million doses for the mRNA primary series. The rate of anaphylaxis was less than 5 per million doses for the mRNA booster doses, which I didn't have time to show you those results. Myocarditis and pericarditis after mRNA vaccines. During days 0 to 7 post-vaccination, both mRNA vaccines were associated with an increased risk of myocarditis pericarditis in 12 to 39-year-olds. The risk estimates of myocarditis pericarditis in 18 to 39-year-olds during days 0 to 7 after 2 doses were modestly higher after Moderna than after Pfizer. And for persons aged 12 to 39, the rates of myocarditis pericarditis 0 to 7 days after primary and monovalent boosters were highest among 12 to 15 and 16 to 17-year-olds. Evidence suggests that there's an increased risk for myocarditis and pericarditis following monovalent booster doses for some age groups, and there's no current evidence for an increased risk of myocarditis pericarditis following bivalent boosters. However, uptake was low in the age groups expected to be at highest risk. Next slide. So for ischemic stroke, this rate ratio met signaling criteria consistently for 8 weeks, but slowly attenuated and now does not. And at the end of signaling did not meet signaling criteria, end of surveillance did not meet signaling criteria. Temporal clustering 13 to 22 days after vaccination was significant at the initial signal, but also attenuated as the rate ratio estimated attenuated. Some supplemental analysis not shown here, but using unboosted concurrent comparators showed a rate ratio of 1.07, not statistically significant. And then analyses evaluating simultaneous high dose or adjuvanted flu dose showed a rate ratio of 1.59, as you can see. Some separate analyses did not detect an elevated rate ratio for stroke after flu vaccine. Again, that was data not shown. And then finally, GBS after Guillain-Barré after Janssen findings were consistent with association between increases of Guillain-Barré syndrome and Janssen COVID-19 vaccine. Next slide. So here I've included just a summary of all the chart reviews we do. There's not much to say except just to have this available for anyone who's interested to see what charts we did review and what age group and what vaccines. Next slide. So I just want to take a minute to really just make a one slide about talking and thinking about the challenges in rapidly generating vaccine safety evidence during the pandemic. These are by no means all the challenges, but these are, I think, the ones that, to me, and this is just my opinion, that are what I feel are some of the most ones from my point of view, was that the vaccine uptake was early and unpredictable. And that was one of the rationales we used for using the vaccinated concurrent comparators. However, most RCA findings came early and for the most part were mostly unchanged since the fall of 2021, not entirely, but mostly. The VSD COVID-19 RCA analytic methods have been hard to understand. We believe that vaccinated concurrent comparators are less vulnerable to bias, but it's an unfamiliar approach that is difficult to explain how the follow-up in the comparison interval is concurrent, and that is on the same calendar day with the follow-up in the risk interval. However, as we're all aware, intense public attention on COVID vaccine safety meant we frequently communicated preliminary results on short notice, and methods that are hard to concisely explain and understand pose substantial challenges. Number 3, our vaccine safety questions frequently changed and expanded, requiring us to rapidly adapt our surveillance to include new outcomes in new age groups. And it was challenging to digest and interpret large amounts of potentially relevant data and results that we put, quote, on the shelf weekly, for example, comparisons with unvaccinated people. However, these supplemental analyses were available should a safety concern arise from VSD or elsewhere. Next slide. So just in terms of future considerations, 2023 VSD COVID-19 RCA surveillance is complete. So future studies at the VSD may consider further investigating. Really, there's 2 in light gray, which I'm not going to focus on too much since those vaccines aren't actually in use. But ischemic stroke after concomitant bivalent vaccines and flu vaccines in over 65-year-olds in future seasons in terms of potential future study. Next slide. And with that, I just really want to just comment and just really say it really does take a village. And every person on this list who's named has just been instrumental in all what has been really quite an undertaking for the last 3 years. So I also want to personally thank them all. Thank you. Next slide. And just to acknowledge again all the VSD sites, CDC, and in particular Northern California, my team at Northern California, and then Marshfield Clinic as well. I think that's I'm happy to take any questions.
Thank you. I want to thank both of our presenters, and we are a bit far behind in our agenda, so I'm going to ask that any questions that come up in this session be related to the decision that we have in front of us today. Dr. Shimabukuro.
Hi, Dr. Lee. This is Tom Shimabukuro. I'm the director of the Immunization Safety Office, and I just want to say that as we transition from pandemic response to the 2023 24 monovalent COVID vaccination program, we wanted to use this as an opportunity to sum up the findings from our active surveillance for the entire pandemic response. And I want to thank Dr. Klein and her colleagues at Northern Cal and all of the sites at VSD for all the work they've done during the pandemic, and just want to reiterate that we have benefited substantially from the experience and knowledge gained over the past several years, and we plan to carry this forward as we transition to monitoring the safety of the 2023-2024 monovalent vaccines. We will continue to do an enhanced monitoring, focusing on pre-specified outcomes and adverse events of special interest, and we will be vigilant in monitoring COVID vaccines as we transition to this new phase of the COVID vaccination program. Thank you.
Thank you, Dr. Shimabukuro, for setting the context there. Dr. Lair.
Thank you very much for a wonderful session on safety. My specific question is, how did you choose 21 days for your range for comparator groups? Is there a biological reason, or where did that come from? Thank you.
Yeah, that's a great question. And that actually harkens back to when we were designing the protocol back about 3 or 4 years ago now, I guess. That was before there actually any vaccines were even authorized. But we did know that there's 3-week recommended intervals between dose 1 and dose 2 of the Pfizer vaccine. And so we discussed a lot of different possibilities, but in the end, we decided that it seemed to make the most sense to keep it as 3 weeks because of the dosing schedule of the original primary series. And so.
Thank you, Dr. Paling.
All right, thank you both for great presentations, and thank you for all the work on evaluating the vaccine safety and reviewing that with us. One of the questions that I have is, we've talked a lot about the myocarditis and pericarditis and the peak in the children, and that really was present with the primary series, and particularly the second dose. And we don't see that in bivalent vaccines. In Canada, we saw that when you space the vaccines out by more than 2 months or 8 weeks, we saw a decrease. Do you think the additional time could be contributing to the change for children? Thank you.
Well, I think, as you know, we did talk about this before. We do see an increase, both rate and risk we did see it from monovalent boosters as well for the teenagers, and those actually did have quite a bit of time from that, the spacing out from that particular dose. Whether that is really the answer, I don't know. To be honest, I don't know the answer to that question. We, of course, as I think we discussed in previous meetings, that we weren't ever able to examine the risk of different intervals because we had incredible adherence within the VSD in terms of the initial primary series, and whether spacing would have made a difference at that point. I'm not sure that we've seen that same sort of impact for the monovalent booster, in which we did see an increased risk as well.
Thank you, Ms. Bata.
Thank you, and thank you, Dr. Klein. I really appreciated that comprehensive overview. Was there any data that you've been tracking related to Novavax vaccine? And I know we won't be voting on that today, but that is an important part of our considerations in the broader recommendations.
Yeah, what I can tell you is that we haven't been tracking it beyond what our uptake is, and in the VSD for our total uptake for the Novavax vaccine was 3,779 doses.
This is Dr. Shimabukuro. There was a recent publication looking at VAERS data for Novavax. I believe there were about 69,000 doses administered that were captured in the COVID data tracker nationally, and the findings from the post-authorization surveillance were consistent, generally consistent with the findings from the pre-authorization clinical trials, and importantly, there were no cases of myocarditis observed after or reported after those 69,000 doses.
Thank you.
Thank you. I don't see any additional hands raised at the moment, so I'm just going to ask a question to Dr. Prosser. Well, thank you both again for the presentations. Dr. Prosser, I had a question, and maybe it's not a question for you, but just maybe a question to the manufacturers. But number one, I was very appreciative of the fact that you looked at age-specific analyses as well as the pooled analysis across age groups for those 18 and older, because we do inherently recognize that the benefit-risk balance is different for different populations. We can't always predict who's going to get COVID or have severe COVID, but at the same time, being able to just disaggregate it in that way was very helpful to me. I will say it seems like that there is the estimates are exquisitely sensitive to the cost of vaccine. So I'm wondering if you could put up slide, I don't remember, it was like maybe 31 or something like that in your slide deck, the tornado diagram. And part of the reason I'm asking is because we're making an assumption and we incorporate cost effectiveness in our decision making and as part of the evidence to recommendations framework. So I just want to make sure I have a good understanding that these costs are reasonably stable estimates. So if we can pull up the tornado diagram, sorry, I don't know what slide it is.
Slide 38. Slide 38.
Oh, okay, sorry, got it totally wrong. Yeah, thank you.
This one here, yeah.
Perfect. Yeah, I think this is incredibly important for us to just have a conversation about. And I wonder if our colleagues from the manufacturers would be able to comment on the anticipated price, because it makes a huge difference for this particular age group. Okay, I don't see any manufacturers raising their hands or at this moment I'm asking, but when we go to the next section, if you're not able to answer in this moment, I will ask again in the later section during those presentations. Dr. Paling.
Grace, thank you for asking this question. It's exactly what I was thinking as well. And in particular, Lisa, Dr. Prosser, could you help us understand where does it change from gray to blue?
Sure, that's at the base case value noted at the bottom of 115,588, because that's the base case incremental cost effectiveness ratio.
Yes, but for the cost of the vaccine, we see that.
Oh, yeah, sorry. So the base case value is $120 per dose in this analysis.
Okay, and so okay, got it. So $120 is there. Thank you.
Yep, that's right.
Thank you. Ms. McNally.
Dr. Lee, thank you. Can you hear me okay?
Yes, we can. Thank you.
Okay. Have other countries started to use this monovalent vaccine and report their experiences? And I'm sorry, I'm not sure who the right person to address that question would be to. Thank you.
I wonder if we can ask our implementation colleagues at CDC if they have awareness of use in other countries. Or I don't know if the FDA would be able to comment. I actually don't know about EMA approval or other agencies.
Apologies, I was having issues with my mic turning on. We are not aware of any countries using the XBB vaccine yet, although I'm sure it's under review in other places.
Thank you. Any additional questions? Okay, thank you, everyone. I'm going to hope my colleagues forgive me and say that we're going to return at, let's return at the top of the hour. So at 00, whatever time it is in your time zone. Thank you, everyone. And we'll take a brief break. Thank you to our presenters, and we'll return for the next session at the top of the hour.